नाही, पण हे झालं पाहिजे. करतोस सर्व.
काही जणांना रजिस्टर करण्यात प्रॉब्लेम येतो, तर काही प्रॉब्लेम आहे का सर? विकास
नाही
करणे
मॅडम,
सरांचा मेसेज आहे.
नाही, तो जो ग्रुपवर मेसेज पाठवलाय ना मॅडम, त्याला रजिस्टर करावं लागेल अगोदर. आणि
हो, नाही
रजिस्टर
ते
केल्यानंतर
रजिस्ट्रेशन इज क्लोज म्हणतात, त्यांचा मेसेज आला मला.
अरे
मग
बापरे,
बाकीच्या लोकांना युट्यूब वर बघावं लागेल का?
युट्यूब बघावं. 100च्या पेक्षा जास्त झाले युट्यूबवर.
पण आता जास्त नाही आहेत
पण हे
पार्टिसिपंट्स मॅडम.
सॅम्स बेरर्स आहेत ना, त्यांना
हा,
करावं लागेल ना आपल्याला.
त्यांना करावं लागेल, त्यांना सांगावं लागेल मॅडम.
विकास करणे सर.
हा, होस्ट कोण आहे त्यांना सांगावं लागेल मॅडम, त्यांना अलाव करा म्हणून. कारण टिल 6:30 दे शुड अलाव देम.
हॅलो
हा.
हॅलो.
हॅलो.
हा मॅडम, आवाज येतोय का माझा?
होय.
हा,
गणेश
गणेश.
सर.
हा मॅडम, युट्यूब लिंक चालू केली मी. युट्यूब
नाही
हो,
नाही,
पण
पण
ते
गणेश इकडे
ऐका ना.
13च लोक आहेत ना, इकडे 12च आहेत.
नाही नाही, आणि ते बाकीचे ऑफिस बेअरर्सला जॉईन व्हायला प्रॉब्लेम होतोय. आणि बाजवा सर ड्रायव्हिंग करत होते, त्याच्यामुळे त्यांना रजिस्टर करायला पण थोडा उशीर झाला, तर त्यांना अलाव
जॉईन
करावं
करता
लागेल
येईल ना
आपले
आपल्याला.
मॅडम?
100च्या वर कर लिमिट, जसं तू ISA बोरिवलीला केलेलं.
ओके ओके ओके.
तसं करा प्लीज.
रजिस्ट्रेशन लिमिट का?
हा,
हो हो,
रजिस्ट्रेशन लिमिट वाढवा.
कारण
रजिस्ट्रेशन इज क्लोज
रजिस्टर
असा मेसेज
करणारे
येतोय.
110 जरी असला तरी तो अजून जॉईन नाही झालाय, त्याला जॉईन व्हायचंय, आणि जॉईन फक्त 12 लोक झाली.
बरेचशे ऑफिस बेअरर्सला जॉईन व्हायचंय, रजिस्टर होत नाहीये. करणे सरांचा मेसेज होता, कॅनॉट रजिस्टर म्हणून.
नाही, ते कारण काय होतंय, मला वाटतं काही लोकांनी रजिस्टर करून टाकलं होतं पूर्वी, त्यामुळे 100चा आकडा जर क्रॉस झाला असेल तर ते येत नाहीये. तर ते लिमिट जरा वाढवा ना गणेश.
किती हे वाटतं, वर स्क्रीन करतो. 15 पार्ट सुरू लिहिलं फक्त तो, बरोबर.
तोपर्यंत अपर्णा मॅडम, स्लाइड शेअर झाल्या का? ट्राय केलं का? तुम्ही म्यूट वर आहात.
तर कसे सरांना एकदा आहेत का सर? तर कसे सर?
नाही, लिस्ट मध्ये दिसलं आपल्याला.
तर कसं सरांचं नाव दिसत नाहीये मॅडम लिस्ट मध्ये. पार्टिसिपेंट
हो,
16च दिसत आहेत.
मी जरा सगळ्या ग्रुप मध्ये टाकते परत. ओके, करणे सरांनी मला पण लिहिलेलं आहे की लिंक क्लोज दाखवते. गणेश, ओपन केलंस का रे बाळा? गणेश, आपल्याकडे 17च लोक आहेत.
गणेश, नाही तर काही जणांना डायरेक्ट लिंक द्या ह्या ग्रुपवरचे. त्यांना आता रजिस्टर करायला पण वेळ नाहीये.
हो.
Hello, good evening, everyone. Dr. Gupta here from Nasik.
Good evening, Professor Gupta, sir.
I feel what everyone has to do is go to the email link, and that is taking you to to this. If you go on the WhatsApp group that you have sent, it is not connecting you to this. This is what I realized.
म्हणजे व्हॉट्सअप ग्रुपवर जे पाठवले ते फक्त रजिस्टर करायला आहे.
रजिस्टर साठी एक्झॅक्टली. आणि जे लिंक आलेलं आहे मेलवर ना, ते मेलवर तुम्ही क्लिक केलं लिंक, देन यू गेट द प्रॉपर लिंक ऑफ जॉइनिंग द वेबिनार. And all those who could not join, ask them to go to open their email ID, the welcome mail, and click on that link. Then you will be joining.
स्लाइड दिसत आहेत का?
हो, दिसतं.
स्लाइड दिसत आहे.
हा, ठीक.
हॅलो हॅलो मॅडम, आवाज येतोय का?
केलं का गणेश?
मॅडम ते आता मीटिंग चालू झाली ना, आपल्याला सेटिंग चेंज नाही करता येत त्याच्यामध्ये, आता चालत नाही, ते चेंज करता येत नाही.
बरं ठीक आहे.
हो हो.
मग आता बाकीचे सगळे कसे जॉईन होणार आहेत?
युट्यूबवर मी चालू केली मॅडम लिंक.
नाही पण आता डेलिगेट्स सगळे
त्यांनी रजिस्ट्रेशन केलं नाही का मॅडम अगोदर?
बाजवा सरांचं ते ड्राईव्ह करत होते,
हम्म.
कोणाला
त्यांचं
आता
रजिस्ट्रेशन.
बाजवा सर कसे जॉईन होतील बाळा?
हा.
मॅडम त्याला ऑप्शन नाही, आता रजिस्ट्रेशन केल्याशिवाय इन होता येणार नाही.
मग रजिस्ट्रेशन क्लोज काहीतरी करता येईल का, वाढवता येईल का?
मॅडम तुम्हाला ईमेलवर लिंक आली का एखादी?
एक काम करू का, माझ्या ईमेलवर आलेली लिंक मी
गणेश
सगळ्या
हो
ग्रुपमध्ये
गणेश
टाकू?
हो.
मेलवर आलेली लिंक टाकता येईल का सगळ्यांना?
एकदा
टाकते, तेच
एकदा
करते.
एक जण शेअर करून बघा सर, आणि
हो,
जर
मी
त्यांना
टाकते
जॉईन करता आलं तर
आणि त्यांना
बघा
सांगते
सर.
वाईल जॉईनिंग चेंज युअर नेम म्हणून असं करते.
हो. एक जण करून बघा मॅडम अगोदर,
हा तेच
कारण की
करते.
आता कसं मीटिंग चालू झाली ना, आपल्याला चेंज करता येत नाही सेटिंग.
नाही मी मला जी आलेली आहे ना ती टाकते.
हो.
शेअर लिंक. ओके. मी मला आलेली लिंक टाकते. प्रणा मॅडम, करणे सरांना फोन कराल का? त्यांना मी पर्सनल वर
मेसेज
लिंक
केलाय
पाठवली आहे.
त्यांना, केला मेसेज केला मॅडम, आणि लिंक पण पाठवली.
हा.
हरकत सरांना फोन करायचा का?
हो, कराल का?
हो.
मॅडम
मॅडम केलाय.
तिथं मेसेज येतो की ऑलरेडी जॉईन दिस मीटिंग ऑन अनदर डिव्हाइस,
हो.
त्यामुळे तेही जमणार नाही.
दिवातिया सर जॉईन
करायचं.
झाले. वेलकम दिवातिया सर. थँक्यू
वेलकम
सो
सर.
मच.
वेलकम सर.
गुड इव्हनिंग.
गुड इव्हनिंग सर.
गुड इव्हनिंग
evening.
सर.
Good evening.
वेलकम ऑन बिहाफ ऑफ ISC Ambezubai and
Thank
Parade.
you. Congratulations, ISC Ambezubai, for it.
Thank you.
Good evening, Shilpa. Good evening, Balaji. Good evening, sir.
गुड इव्हनिंग सर.
मॅडम, नाऊ 2 स्पीकर्स आर अनेबल टू जॉईन. आता काय
हा, मी
करायचं?
आता जी लिंक टाकली आहे ना आपल्या ग्रुपमध्ये सचिन सर,
हा.
ती त्यांना म्हणा त्याच्यावर जॉईन व्हा. सगळे शिल्पा दिसतील.
हो.
नाही मॅडम.
जॉईन ऑन
हॅलो
दॅट.
नाही मॅडम, होता येणार नाही. गणेश
होता
आता
येणार नाही मॅडम.
नाही होता येतं. माझ्या लिंक वरनं त्यांना जॉईन होऊ द्या. गणेश, होता येईल ना?
नाही मॅडम, नाही होता येणार, कारण की मी तुमच्या लिंकला क्लिक करून बघितलं, तर मला मेसेज आलाय की डिफरंट डिव्हाइस वरनं जॉईन आहेत म्हणून.
आता कसं करायचं?
डिव्हाइस वरनं.
Good evening, Devatia sir. I request everyone to go on the email link that has been sent to their mail. Everyone has got a separate email.
गणेश, एकदा अभिजितशी बोलून काहीतरी बघा, ती लिंक पटकन शेअर करता आली ग्रुपवर, डायरेक्ट जॉईन करायची.
हो सर, ओके.
अच्छा, यू हॅव ऑलरेडी जॉईन दिस मीटिंग म्हणते. ओके ओके.
हा, रजिस्टर केल्यानंतर एकाच डिव्हाइसवर आपल्याला जॉईन करता येतं मॅडम.
मी आता
That's why let's ask everyone to go on the email.
पण काही फॅकल्टीजने पंकज सर हे नाही केलं ना रजिस्टर.
Oh, no, that is wrong.
Hello everyone.
Hello. Hi, Parna.
हॅलो पर्णा मॅडम.
Hello sir.
हॅलो हॅलो, वेलकम पर्णा मॅडम.
Thank you. Hello.
हॅलो.
हाय.
हॅलो पर्णा.
Hello sir.
पर्णा मॅडम, ही
Yes.
युट्यूबची लिंक दिली होती ती टाका ना जरा ग्रुप्स मध्ये, गणेशने आपल्याला.
हा. ओके. ग्रुप्स मध्ये टाकते.
हॅलो.
हॅलो, हा गणेश, काय करतायत
हॅलो.
बरं का?
हा, डॉक्टर हर्षद स्पीकिंग मॅडम.
हा हर्षद सर बोला.
हा, ईमेलवर जी आपल्याला लिंक आलेली आहे त्याच्यावर पण जॉईन जर होता आले नाही तर त्याच्या खाली अजून एक ईमेल डायरेक्ट लिंक आहे, ती कॉपी करून डायरेक्ट झूम मीटिंग मध्ये टाकलं तर आपल्याला जॉईन होता येईल.
नाही ना, तीच लिंक मी ऍक्च्युली ग्रुप मध्ये फिरवली.
नाही, स्वतःला प्रत्येकाला वेगवेगळी लिंक आहे ती, त्याच्यामुळे त्याचं प्रत्येक डिव्हाइस वरून वेगळ्या जॉईन व्हावं लागेल.
हर्षद सर, नाही प्रॉब्लेम कुठे येतोय फॉर
अच्छा, रजिस्ट्रेशन
फॅकल्टी.
केलेलं नाही लोकांनी.
हा, ऑलरेडी
नाही,
आपलं
नाही.
आय थिंक 100 रजिस्ट्रेशन झालं, त्यामुळे
अच्छा.
त्याच्या पुढे ते नाही रजिस्टर अलाउ
मग
करत.
आपल्याला युट्यूब लिंक वरूनच जावं लागेल मॅडम.
हो, पण मग बाजवा सर कसं काय जॉईन होतील?
हा, बाजवा सर. नाही, माझं म्हणणं आहे मीटिंग आयडी आणि पासवर्ड टाकलं तर नाही करता येणार का? युजली जसं झूम मध्ये करता येतं तसं.
नाही मॅडम, हे झूमच आहे आणि इथं रजिस्ट्रेशन आपण
Zoom झालंय.
इनेबल केलेलं असल्यामुळे करावंच
हा.
लागेल. आणि आता मीटिंग चालू
पण
असल्यामुळे मॅडम ते सेटिंग पण चेंज होणार नाही.
हो, पण आता आपल्याला बाजवा सर आणि त्यांना अजून
जर
बाला भास्कर सर पण.
जर मॅडम 2 स्पीकरचा जर प्रश्न असेल तर समजा 2 जणांना लेफ्ट व्हावं लागेल कोणाला, किंवा युट्यूब
एक
मधनं
काम
जॉईन व्हावं
करते.
लागेल आणि ती लिंक ते यूज करतील असं.
हो, ठीक आहे, चालेल ना. मी
मी असं
मग सांगते
करते
कोणाला
आता,
तरी.
अपर्णा मॅडम,
हा.
मी आउट जाते आणि
नाही
माझी
मॅडम, तुम्ही लागतील आम्हाला गायडन्स थोडंसं.
नाही आपलं छान झालंय की हो, काल माझी गरज नाहीये.
Dr. Bajwa is already there on the group.
बाजवा सर आहे.
Just see the list of participants, you'll find his name.
रजिस्टर केलंय का त्यांनी? हॅज ही रजिस्टर्ड?
I can see his name on the list, participants list. After Ganesh Khandekar.
हो, आहे.
His name is there. Only maybe he is still unmuted and video is off. As you said, he was driving, na? Even Divatiya sir is right now offline.
So he'll be able to
43.
join, no?
Exactly.
I'm He's online, already only joined. I'm off video.
No, he is there. He is
Okay.
there. Bajwa sir is there.
Exactly.
And
आपण
and
चालू
Bala
करावं मला
Bhaskar sir?
वाटतं.
I am
Ah,
just on
चालू
another
करून
call.
टाकूया.
Good evening. I'm on another call. I will be joining in 2 minutes.
Yes,
Yes.
yes.
ओके सर.
We can start then.
Should we start, madam?
येस,
Yes.
Dr. Tarkase sir has joined. Just check.
Just a
Bhaskar
second.
sir.
I am checking, madam.
थोडं दे.
Yes.
I am not seeing his name, madam. Tarkase sir. एकदा फोन करा सर.
जॉईन होतो बोलले ते मला.
अपर्णा मॅडम, यू कॅन स्टार्ट. मी यू आर कॉलिंग.
2 minutes, madam. We will see the current position of Tarkasi sir, and then we'll start.
Tarkasi sir will be joining. He is also facing the difficulty in joining.
Joining.
So one of our lecturers is going to leave and he is going to join.
So should we proceed?
समजा जॉईन होऊ दे.
नाही नाही ठीक आहे ना. We can start no sir.
मॅडम जे सर लेफ्ट होणार असतील ना तर त्यांची लिंक ते सर यूज करतील ज्यांना जॉईन व्हायचं ते.
हो हो तसं. आणि नंतर मग वायसा वर्षा करता येईल ना आपल्याला.
आपण चालू करूयात पण मग.
हो.
हा चालू करूयात आपण. हो.
Should we start, madam?
Yes.
Yes.
Sir, you can
So,
start.
so a warm welcome and a good evening to all the delegates as well as all the attendees who have joined the today's webinar arranged by ISA Paradi Ambajogai branch on anemia and anesthesia. So I welcome Dr. Honorable Devitia sir, President of ISA, Bala Bhaskar sir and Sukhvinder Singh Bajwa sir, who is a great academician. So I would like to welcome all the delegates, and I will hand over this session to Dr. Lohia sir to welcome the delegates and to start the session.
Hello everybody. Happy New Year to all, 2024. It gives me immense pleasure to get started with our first webinar session on anemia and anesthesia, in which we are all going to discuss about anemia and its implication towards anesthesia in various conditions. First of all, I take this opportunity to thank Dr. Shilpa Tivaskar ma'am for this great initiative of this webinar session. She had taken a lot of pains to communicate everybody in this group and provocate for this webinar session. And at last, we got the kickstart for this first of its kind of webinar session in ISA Ambajogai group. We, the Ambajogai ISA group, were lagging behind in the academic sessions and were inactive also. It was due to communication gap we had. But as said, Shilpa ma'am has initiated us, got us, and the mission started. In future also, we all are committed for the continuation of this webinar session, which is meant for our academic excellence in the field of anesthesiology. Today, we are feeling proud and lucky to have national iconic dignitaries for this webinar session of anesthesia, anemia and anesthesia. I welcome all wholeheartedly. Dr. Jigeshu Devatia sir, President ISA National, past Editor-in-Chief, Indian Journal of Anesthesiology. Dr. Sukhminder Singh Bajwa sir, Honorary Secretary ISA National, past Associate Editor-in-Chief, Indian Journal of Anesthesiology. Dr. S. Bala Bhaskar sir, past President ISA National, past Editor-in-Chief, Indian Journal of Anesthesiology. I also welcome all our state dignitaries who are on this webinar session. First, Dr. Balaji Asegaonkar sir, President, Society of Anesthesiology, Maharashtra State. Dr. Avinash Bhosle sir, Vice President, Society of Anesthesiology, Maharashtra State. Dr. Rajesh Tagadpalle sir, Honorary Secretary, SAMS. Dr. Anita Nehte ma'am, President-elect, SAMS, and Dr. Parna Thakkar ma'am, News Editor, Society of Anesthesiologists, Maharashtra State. After this welcome speech, I hand it over to Dr. Tarkase sir for the further proceedings of the webinar session. Thank you very much.
Tarkase sir,
Tarkase sir joined.
Yes, sir joined.
Hello, sir. Hello, Bajwa sir. Welcome
Thank
to
you,
the
ma'am.
webinar.
Thank you,
Yes.
ma'am, and good evening
We
to
are very
everyone.
nice. We are very pleased to have you with us.
Yes,
Yeah.
sir.
Good
Okay.
evening, President
Ma'am,
sir.
yes.
Good evening, then all the dignitaries of Maharashtra State, the SAMS academics, my GC colleagues, Dr. Manisha
Yes.
Katikar, Dr. Pankaj. I think the rest of all may be joining. I think
Yes.
you people have done a good job and keep it up.
Thank you, sir.
Thank you, sir.
Thank you, sir.
I will take the next proceedings, Bhautankar sir,
Yes,
and I'll
sir.
proceed further.
Yes, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. After having this brief introduction, before beginning the academic session, let me first introduce all of us in brief regarding our experts for this session today. We are
Sorry
having
to interrupt, Aparna madam. Do you want
yes.
to introduce our national GCs? Tarkase sir was going to do that.
Madam, you can play that
You
role.
can also introduce, ma'am. Yes, you can also introduce.
नाही तुम्ही करा ना please.
Aparna madam, you can play the role of Tarkase sir because you are there with him in Ambejapur. So there's no problem.
Okay.
Should I complete the?
No problem.
ma'am,
Dr. Shilpa, Dr. Parna, no be formal. Everybody is here is comfortable. कोई ज्यादा
Yes,
ऊपर
sir.
नीचे वाली बात नहीं है,
On
ठीक है?
behalf of Ambezogai branch, Ambezogai Pareli branch, we welcome our national GC members, Dr. Manisha Katikar madam,
Take ma'am.
Dr. Indrayani madam, Dr. Pankaj Gupta sir, and our West Zone GC, Dr. Chandrasekharan Cham sir. Yeah, sorry,
Yes,
Aparna madam.
yes, ma'am.
Continue.
Yes, ma'am. Thank you, ma'am. Actually, I was not in that flow because that was not my part. So actually,
No formalities.
no,
No formalities.
no, it's okay,
Go
sir.
ahead.
Yes,
Just
yes,
go
yes.
ahead, start the
So,
webinar. Always.
yeah. I'll briefly introduce our experts and then we can start with the academic part. We have
Perfect.
today with our experts, Dr. Jigishu Devatia, sir, who is the professor and head Department of Anesthesia, Critical Care and Pain at Tata Memorial Center, Mumbai. He is the president of ISA and past editor-in-chief of IJA. He was the past president of Indian Society of Critical Care Medicine and All India Difficult Airway Association. And he is the president of Society of Onco-Anesthesia and Perioperative Care. He has received training in intensive care in Australia and is a PG diploma holder in medico-legal systems from Symbiosis University. He has over 195 publications in national and international journals, and he has a vast administrative experience. And he is the chairman of Hospital Infection Control Committee, chairman of Hospital Safety Committee, and a past member of Institutional Ethical Committee and a member of Authorship Committee. His contribution during COVID pandemic was also noticeable, and the guidelines for airway management during COVID-19 and the ICU guidelines were designed under his guidance. Besides this, he is the member of various National Board of Education, and he is awarded the Fellowship of American College of Critical Care Medicine and Presidential Citation of Society of Critical Care Medicine USA. I welcome with warm regards from ISA Ambezogai in Parari, Dr. Devatia sir. Our next expert we have with us is Dr. Sukhminder Jeet Singh Bajwa sir. He is the professor and head Department of Anesthesia at Gyan Sagar Medical College, Patiala. He is the honorary secretary of ISA National and past associate editor-in-chief of IJA. He has a major role in taking IJA to newer heights. He is the ex-editor-in-chief of Northern Supplement of IJA and associate editor-in-chief of Journal of Anesthesiology and Clinical Pharmacology. He is the ex-honorary secretary of Punjab State ISA and ex-National Governing Council member of ISA. He is the ex-board of director of PG studies at Baba Farid University of Health Sciences, Punjab. And he has contributed to almost 8 anesthesia books, including the great Lee's Synopsis of Anesthesia, in which he has contributed to anesthesia for endocrine surgeries. He has over 400 national and international publications with 7 national guidelines in anesthesia, medicine, and endocrinology. He has 14 years of editing and reviewing experience, and he has received academic appreciation from Sir R.D. Miller in 2003. He was awarded as the KPR Best Young Anesthesiologist of India Award in 2012, ISA President Appreciation Award for starting Northern Supplement of ISA IJ in 2015, ISA President Award for Developing Research Methodology module in 2015, and ISA Bhopal Award for Academic Excellence in 2022. His areas of interest are research methodology, obstetric and neuroanesthesia, and emergency medicine. Sir, I welcome you on behalf of ISA Ambezogai and Parai, and we would like to have a good guidance from you.
Thank you, ma'am.
Our
Thank you
next
very much.
expert, Dr. Bala Bhaskar, sir, I guess he has not joined. He has joined what?
No, sir has not
Okay.
joined.
Okay, I'll just say a few words regarding him. Dr. Bala Bhaskar, sir, is the professor at Department of Anesthesiology and Critical Care at WIMS, Ballari. He was the past president of ISA National and past editor-in-chief of IJA. He is a member of Publication Committee, World Federation of Anesthesiologists, and member of Institutional Ethical Committee, WIMS, Ballari. He is the chief coordinator for formulation of 5 ISA practice guidelines. And he is the member of Board of Studies, both for undergraduate and postgraduate. He is the editor of the journal at Rajiv Gandhi University of Health Sciences. He has over 60 publications, and his areas of interest are for research, guidelines, education, and simulation. I welcome him on behalf of ISA Ambezogai, and we are waiting for him to join this session. His message was he'll be joining the session a bit late, but we'll be very happy if he joins it early. So, again, on behalf of ISA Ambezogai Parari, I welcome all the delegates and the participants who have joined for this webinar, and hand over the next session to our first speaker, Dr. Tarkasi sir. Before that, I request Dr. Sachin sir to introduce Dr. Tarkasi sir and introduce his topic as well. Thank you.
So to introduce Dr. Tarkasi sir, he is the professor and head of the department at SRTR Medical College, Department of Anesthesia, and he is then secretary of Ambezogai Parari Maharashtra State ISA branch. He is a governing council member of Maharashtra State ISA branch. So today's topic for Tarkasi sir, what he chosen for today's topic is anemia and body system. So I kindly request Dr. Tarkasi sir to have a word on this anemia and body systems. Madam, has he joined?
Sir, he has joined through some residents link, and
so
can you see him?
Tarkasi sir?
You want to call him Aparna, madam? Or we want to take the next speaker, Sachin sir?
I am calling, madam. I am calling just. Just now I had a call with him. He is not able to join the session.
Now he is trying again for joining the session.
Can Aparna madam start?
Should we proceed with the next lecture?
Yeah, we can start.
So
we can start with the next lecture.
Yeah,
Yes.
so the next lecture or today's session is anemia and type of anesthesia. Will be presented by Dr. Aparna Kulkarni madam. She is an associate professor at SRTR Medical College, and she is vice president of IIC Parari Ambezogai branch. She has presented various papers in national conferences, and also she won the best paper awards in the conference, and she also had won the Corona Warrior Award for her excellent work in the COVID-22 20, and as well as her topic of interest is in obstetric anesthesia. So my kind request to Aparna Kulkarni madam to have a word on anemia and type of anesthesia. Over to you, madam.
Okay. Am I audible?
Madam, click on the from beginning.
Yes, you are audible, madam.
Okay. Thank you. Is my screen visible?
Yes,
Hello?
madam. Yes.
Yes. Okay, so good evening, and I'll be dealing with the second topic of this session, that is anemia and type of anesthesia. Now, as you all know, anemia, it broadly affects all the systems of the body, and therefore, while dealing while dealing for giving the anesthesia to such patients, we have to consider the patient as a whole and the various changes which have taken place in this patient, and then we have to decide the plan of anesthesia. So, before deciding the plan of anesthesia, like for any patient, we have to have a preoperative assessment of these patients. In that, we have to take a thorough history of these patients with respect to the symptoms related to anemia, like the symptoms like breathlessness, anginal chest pain, fatigue, palpitation. So these are the auto-regulatory mechanisms which have developed in the patient after developing anemia. Similarly, we should also have a history regarding the symptoms of bleeding, whether that will elicit the cause of the anemia. Also, symptoms related to the underlying illness, like any symptoms related to malignancy, renal failure, or endocrinopathies like thyroid disorders, infections, and liver disorders. All this can point towards anemia of chronic diseases. Also, we should ask about past history of anemia or blood transfusions, which can elicit that the patient has a chronic history of anemia with frequent requirement of blood transfusions. History of splenectomy, hemoglobinopathies like sickle cell anemia, or you have to also ask the history of family history, because there can be some genetic disorders of hemoglobin disorders which can run in family, and that can lead to anemia. Social history like occupational hazards, dietary habits like anorexia nervosa, all these can lead to nutritional anemia. So a detailed history is always important before proceeding for anesthesia. After that, a thorough physical examination is important to know the extent of pallor, other signs of pallor like flat nails or koilonychia, then icterus, which can point towards hemolytic anemia, signs of bleeding, or hepatosplenomegaly lymphadenopathy, which can point towards the hemoglobinopathies. Or you should always see for hemic murmur, that can tell you the compensatory phase of the heart, whether the heart is in a compensated phase or a decompensated phase. Also look for thalassemic phases. This can be a indicator for difficult intubation if you are managing this patient for general anesthesia. Then you have to go for thorough investigations of the patient, like CBC, peripheral blood smear, red count. Reticulocyte count helps in diagnosing the type of anemia. Then stool examinations for occult blood, chest X-ray for knowing the cardiomegaly or any compensatory changes which have taken place in the heart. ECG, which is very important to look for any strain pattern which have developed from long-standing anemia, STT changes. These point in favor of decompensatory phase of the heart. And 2D echo. This also gives you the function of the heart. In case of long-standing and chronic anemia or severe anemia, the heart function can be decompensated. So 2D echo will be helpful. Then after that, we have to go for preoperative optimization. Now, if you have anemic patient for anesthetizing, then you have to first optimize the patient. In case of elective surgeries, it's always better to optimize. Now, there was a largest trial which was done, which was called as transfusion requirements in critical care trial. And this trial, what it did is it adopted two strategies. That is, one was a restrictive strategy in which transfusion was given if the hemoglobin was less than 7 grams or hematocrit was less than 24%. And the other was a liberal strategy in which the hemoglobin was given, hemoglobin was 10 grams and hematocrit was 30%. 30%. And it was found that there was no significant difference between the patients in which the blood transfusion was given with restrictive strategy than liberal strategy. Rather than it was found that liberally giving blood transfusions to these patients had adverse effects of blood transfusion. So it was found that the patient who was ASA grade 1 or 2, in that if the HB is 8 or more, then there is no need for blood transfusion. Now, if the HB is in between 8 to 10, what it was found, the decision of giving blood transfusion has to be outweighed. Whether the patient has any coexisting comorbidities, the age of the patient, the type of surgery, whether the patient will bleed or not during surgery. These factors will help in contributing for decision making whether to transfuse or not. So the most important decision whether to transfuse or not, it depends on this. It was decided on this trial, and it was decided that 8 grams % was a guidelines for deciding the transfusion, whether to transfuse or not in the ASA grade 1 patients. Now, why we are worried about anemia in surgery? This is because with anemic patient has a higher risk of infection, longer ventilatory support. Severe anemia can cause end organ damage. And it was found that in older surgical patients who have a hematocrit less than 30, they have a high risk of post-operative delirium if they have anemia. So all these factors are very important, and therefore correction of anemia preoperatively is important. Now, as you all know that anemia, it affects anesthesia. Because anesthesia per se has its own effects on the body. And on top of that, anemic patient has various disturbances in the body. So you have to be very careful while anesthetizing these patients. And for that, you have to have some goals while deciding the type of anesthesia. So what should be the goals while deciding the type of anesthesia? Anesthetizing the patients, you should always avoid hypoxia. You should avoid hypotension and tachycardia. You should avoid hypothermia, dehydration, pain, and you should avoid positions which decrease cardiac output. So all these should be the goals while managing the patients while giving anesthesia. Now, which anesthesia is better? There is always a dilemma whether to give general anesthesia or neuraxial blockade. So in severe cases, that is HB less than 6 grams per ton, it's always better to proceed for general anesthesia. But in case of borderline anemia, you can always go for general anesthesia or you can go for neuraxial anesthesia. If you are deciding for general anesthesia, what are the pros of general anesthesia? There is rapid induction, controlled ventilation. Now, as I already said that you have to avoid hypoxia. So general anesthesia, you can give a controlled ventilation and you can adjust all those parameters and you can have a good oxygen saturation to the patient. And also with the help of various drugs, you can have less hemodynamic fluctuations. But what are the cons of general anesthesia? Volatile anesthetics, they can cause peripheral vasodilatation and increase blood loss and decrease cardiac output. So while administering general anesthesia, sometimes you can have sudden fall in the blood pressure because of these various drugs. Also, because of the sympathetic stimulation, if pain is not taken care of or if there is pressure response is not controlled properly, in that case, there can be increase in blood pressure and there can be tachycardia, which is not advisable in anemic patients. Also, there is risk of aspiration, which is common to all the patients who are given general anesthesia, and delayed extubation in anemic patients. Why? Because these patients have hypoproteinemia in hand with anemia. So there is delayed excretion of the various drugs, and therefore there is risk of delayed extubation or post-operative desaturation. So this can be the cons of general anesthesia. So you have to decide, depending on the type of the patient and the type of the condition of the patient, you have to decide whether to give general anesthesia or not. You can give general anesthesia, but for that you have to have some proper precautions during general anesthesia. For that, you have to go for adequate pre-oxygenation. Normally, we do a pre-oxygenation for 3 minutes. In anemic patients, we can increase it to 5 minutes. Intra and post-operative optimization of cardiac output and oxygenation has to be done properly. You can use various drugs and various measures to decrease the pressure response, provide proper adequate analgesia in these patients so that sympathetic stimulation will be minimized and tachycardia, hypertension will be minimized. Also, you have to maintain the core temperature because hypothermia and hyperthermia has to be avoided. Normal temperature has to be kept. Prevent sudden drop in the blood pressure by giving slowly titrating doses of drugs. Always plan for post-operative analgesia, because general anesthesia, if it is not supplemented with any blocks or any like epidural and all, then the patient can have post-operative pain. That is also not advisable in anemic patients because it can again increase the blood pressure and tachycardia. Therefore, proper post-operative analgesia is advisable. Now, if you are planning for central neuraxial blockade, yes, you also can give central neuraxial blockade. What are the advantages? It has good analgesia. It causes less sympathetic stimulation, therefore less tachycardia, less blood loss, and stable hemodynamics if you are opting for epidural. This can be contradictory because with spinal anesthesia, you cannot have stable hemodynamics. Suddenly, there can be hypotension. So, if you're planning for epidural, you can have somewhat stable hemodynamics. What are the cons? Sudden hypotension, as I already said, with spinal anesthesia, you can have sudden hypotension. Sometimes, because these patients have less hypoproteinemia, there can be higher sympathetic block with the normal doses of drugs which we have used for spinal anesthesia. Therefore, we can always reduce the dose of local anesthetics for giving spinal anesthesia in these patients. Also, hypotension, if it is treated with sudden fluid, fluid administration, then these patients are at risk of fluid overload and pulmonary edema. So these are the disadvantages of regional anesthesia. So in severe anemic patients, usually central neuraxial blockade is avoided. But in borderline patients, you can always go for central neuraxial blockade. So what are the precautions to be taken during central neuraxial blockade? Reduce the dose of local anesthetics, as I already told, because of hypoproteinemia. Use of adjuvants, because so that you can reduce the dose of local anesthetics. Supplemental oxygenation throughout the procedure, which can increase the FiO2 and prevent hypoxia. You should always opt for prompt correction of blood loss intraoperatively. This is because small amount of blood loss also while giving neuraxial blockade can precipitate hypotension, and therefore once this cascade begins, it becomes very difficult to manage the hypotension. And therefore, prompt correction of blood loss is very important. Mild anxiolytics have to be given in these patients, but not oversedation. As I already told that oversedation can cause hypoventilation in these patients in the postoperative period, and therefore only mild anxiolytics are advisable. As I already told, avoid fluid overload for treating hypotension. For treating hypotension, you should always use a balanced technique of vasoconstrictors or vasopressors and fluids. Now, in these patients, while anesthetizing, you have to have a proper intraoperative monitoring, that is non-invasive monitoring, pulse oximetry, blood pressure, ECG, EtCO2, urine output, and in severe cases, you should have a proper CVP monitoring, invasive arterial blood pressure monitoring, and ABG. Thank you. So this was a brief discussion regarding the anesthetic management. I have just covered highlighted points. I would like to ask a few questions to the experts. Can I, sir?
Yeah, madam, because it was a very nice presentation, you can ask
Thank you.
the question to the experts.
Yes. Sir, actually, are there any different guidelines of HB levels for accepting in pediatric patients and adult patients? Would like to ask the questions to the experts. Like,
Diwatiya sir and Bajwa sir.
So I'm Dr. Devetia. Okay, so
yes.
I don't do pediatrics, so I'm not aware of pediatric guidelines.
Okay.
In general, in adults,
yes.
the general guideline is to transfuse as less as possible. Okay, so you mentioned the trick trial which was done in the ICU.
Yeah,
there are,
yeah.
Which again suggests that you transfuse around 7 and as opposed to transfusing around 9.
Yes, yes.
But there are other there are many trials which have been done, and many of them are surgery specific. So, for example, in patients with cardiovascular disease, it is suggested, especially ischemic heart disease, suggested you maintain a slightly higher level of slightly higher threshold. In orthopedic surgery, it suggests that you can make do with a slightly restrictive transfusion. In oncological surgeries, there was one study which suggested that it may have a slightly higher threshold. So in cardiac surgery, they usually want a slightly higher threshold. Some of the guidelines are surgery specific. But in general, what you should do is transfuse as little as possible. And it is not just the hemoglobin which is going to guide your decision to transfuse. Whether there's ongoing blood loss, the potential for more blood loss, whether the patient has significant ischemic heart disease, also whether the patient is having other signs of hypoperfusion even at a low hemoglobin level, or even a slightly higher level. Let's say his hemoglobin is 8. If he's having, say, ongoing tachycardia, hypotension, lactate levels are high, he's got acidosis, maybe you should transfuse even at 8 rather than wait for 7. On the other hand, if the hemoglobin is 8 and everything seems to be okay, you need not transfuse. So it's not just the hemoglobin level, it could also be the other sort of parameters that guide your decision to transfuse. As far as preoperative optimization is concerned, you mentioned about preoperative. I think it is very convenient to give blood to to get the hemoglobin up quickly and not, give fracture today and operate tomorrow. But if you have time, and in many elective cases you do have time, sometimes I understand that other considerations make you take up the patient as quickly as possible, rather than the nature of the urgency of surgery. Intravenous iron is a very good tool to sort of optimize the hemoglobin these days. Current preparation of peroxymaltose and iron, they are very good, and you can give them quite safely. And of course, it takes 2 weeks or so for the hemoglobin to start rising, but they are very good for optimization. For pediatrics, I'll let someone else handle that.
One more question. Like if you have a patient at HB around 6.5 and presenting for instant and drainage of abscess, and there is no blood, I mean the patient there is no blood availability, how ethical is it to anesthetize such patient? I mean, we many a times face such situations, like the surgeon brings the patient, there are no things, we cannot improve the HB immediately, we don't have blood. Then at that time, should we give anesthesia to the patient or reject the patient?
Okay. Again, it's difficult to say that, for example, because an abscess is a sort of a semi-surgical urgent
Yeah,
operation.
it's an abscess, so you have to drain it, right?
Yeah. Now, if the patient is otherwise well, all others has just an abscess and maybe a bit of fever and pain and that something, I guess you could go ahead. If it is not in an area which is likely to bleed or something like that.
Okay.
On the other hand, if the patient is septic, is hypotensive, then you should probably be in a situation where transfusion is available. And if it's going to be an area which is likely to bleed, say it's near some big vessel or near a very vascular area, then again you should probably have this patient operate in a place where there is access.
And sir, one more question. A patient whose HB is around 7, 8, and in that case, if the patient is posted for a routine surgery, should we ask for the coagulation profile, serum proteins, all these investigations? Are they needed really?
Again, it depends on the reason for the surgery.
Say for that matter, abdominal hysterectomy. If the patient is posted for abdominal hysterectomy with HB of 7. 7 or 8 for that matter.
You presume this patient is having bleeding.
Yeah.
So and the hysterectomy, I mean, the commonest causes are, they are not related to coagulopathy. They are mainly related to the changes, prime changes, and so on. I guess you need not ask for all this. But if you've got bleeding and you don't know why the patient is bleeding, even if there's say GI hemorrhage from the esophageal varices or something, then you should ask for coagulation profile.
Okay, it depends on the disease.
If the patient is on aspirin, your coagulation profile may not tell you anything, but if you have some, then you need to stop the aspirin. You need to give platelets and stuff. So again, it all depends on your reason for.
Yes. Okay. Thank you, sir. Anything from Dr. Sachin, sir?
Madam.
Any queries?
Sir, how many days aspirin? And what dose? 75, 150?
Sorry, sir?
You're telling that the aspirin should be stopped.
No. If it is bleeding because of on aspirin, not otherwise. I mean, if the patient is on aspirin and he's having GI bleeding, then maybe you need to stop the aspirin.
Okay.
But if the patient is on aspirin and it's for planned surgery and there is no bleeding, then and he's on aspirin, say for ischemic heart disease, and especially after a stent, then I think you should continue the aspirin. The stopping is only in the context of bleeding for which you suspect aspirin. If there is
clopidogrel and other things.
So clopidogrel we would stop 5 days prior to surgery.
Okay, sir. Thank you.
Yeah. And having said that, if the surgery is superficial and the patient has a stent which is a recent stent, and the integrity of the stent is critical. Let's say the stent has been put within the last 1 month or last 3 months, and it is a superficial surgery, something on the hand or something which is easily compressible or coagulable, then we might the risk-benefit ratio might tilt towards continuing the dual anticoagulant, aspirin as well as clopidogrel. But if it is stent is more than 6 to 9 months old and like an elective surgery, then I think we would stop the clopidogrel and continue the aspirin.
Okay. Thank you, sir.
So to conclude with this, any experts having any questions towards Kulkarni madam? So the questions for the attendees will be taken after the case, all the cases are being presented. So if the experts are not having any questions, can we move towards the next topic, because Tarkase sir is already joined the session. Should
yes.
we move on to another topic, madam? Now, I invite Dr. Tarkase sir, Professor and Head, Department of Anesthesia, SRTR Medical College, Ambazogai, and the Secretary of ISA Branch, Paradi Ambazogai, as well as the Governing Council member of ISA Paradi Ambazogai Branch. So I invite him to present his next topic, that is anemia and body systems. So over to you, sir, Tarkase sir. Tarkase sir. Tarkase sir?
Tarkase sir has joined it.
Yeah. Just we had a call with him also, and he told he is listening and he will present the next topic. Sir, can you call him again?
I can see hand raised by Tarkase sir.
Yeah.
Yes. Even I can see.
So,
Sir, unmute kara.
Tarkase sir?
Tarkase sir, are you there? Yes, he unmuted.
Sir.
Yes, he unmuted.
Sir.
Can
Sir,
you
over
start
to
your
you, sir,
video
for the
also?
next topic.
Hello.
Sir. Over to you for your next topic, sir. Anemia and body systems.
Can you hear me?
Yes, sir.
Yes.
Okay.
Then put on your video also.
Video.
Sir, you start your video also, Tarkase sir.
Yeah. Right. Okay. Sorry, I joined very late because of technical problems, and I will thank to all the dignitaries on this webinar who has participated, and I'm sorry, very sorry to attend lately. So the topic given to me is the anemia and the systemic problems. How anemia affect the various systems in the body. Okay. So let us start with my lecture. It is the first lecture is of Aparna, and she had very well narrated all the points. Now I have to repeat some points again. So blood is compromised of red blood cells, platelet, and various types of white blood cells. Okay. So anemia is a problem of not having enough healthy red blood cells or not having healthy hemoglobin. Right. So my topic is what are the body effects? How anemia affect the body or body system. To start with heart and lung problems. Adults with severe anemia may be at risk of developing complications that affect their heart and lungs. Patient may develop tachycardia, heart failure due to anemia. The lungs overcompensate in order to bring more oxygen, causing breathing difficulty. Low levels of hemoglobin prevent adequate oxygen from reaching the brain. How does anemia affect the blood system? Anemia reduces blood viscosity, decreasing systemic vascular resistance due to enhanced nitric oxide mediated vasodilatation. One thing. Then low blood pressure causes neurohormonal activation, which can increase sympathetic and renin-angiotensin-aldosterone system activity, impairing renal perfusion and expanding the extracellular space, which may cause the edema. Now, how does anemia affect the heart? Anemia itself can worsen cardiac function, both because it causes cardiac stress through tachycardia, because the demand of body is increased and heart has to pump fastly, so there will be tachycardia, and heart has to increase the stroke volume. That means the contraction of the heart. Because of reduced renal blood flow and fluid retention, adding further stress to heart. What are the immune systems which can be affected? ACD, that means anemia of chronic diseases. Anemia that is found in people with certain long-term chronic medical conditions. Anemia of chronic diseases, which are autoimmune disorders, just as Crohn's disease, systemic lupus erythematosus, rheumatoid arthritis, and ulcerative colitis, and cancer, including lymphoma and Hodgkin disease, which now certain viruses may cause anemia. Viruses that have been linked with aplastic anemia include hepatitis, Epstein-Barr, cytomegalovirus, paravirus B19, and HIV. Now, main problem in our area, rural area, is the pregnancy. What happens in pregnancy? There will be dilutional anemia, right? So we have to treat that with various methods. So immune system might attack your bone marrow during pregnancy. The high rate of proliferation required of the bone marrow renders highly susceptible to the influence of external factors. Now, what are the causes of anemia? One is the destruction of red blood cells earlier than normal. The lifespan of RBC, normal RBC, is 90 to 120 days. So, destruction of anemia due to various causes. Second is the long-term or chronic diseases such as chronic kidney disease, cancer, ulcerative colitis, or rheumatoid arthritis. In rheumatoid arthritis, we are taking so many drugs. They are acting on bone marrow. And production of the red blood cell is from the bone marrow. So, that is one factor. One form is thalassemia or sickle cell anemia, which is inherited. Then pregnancy. Problems with bone marrow are like lymphoma, leukemia, myelodysplasia, multiple myeloma, or aplastic anemia. Now, slow blood loss in day-to-day life, like very heavy menstrual period, stomach ulcers, like hemorrhoids and all these things. So, slow or chronic blood loss. Okay. Then sudden heavy blood loss in accident or during any operative procedure. Sudden blood loss is again the cause. What are the symptoms? Feeling weak or tired more often than usual with exercise in normal patient with slow blood loss. Then headache. Then problems with concentration of thinking, irritability, loss of appetite, numbness and tingling of hand and feet. Then some causes are lightheadedness, pale skin color, shortness of hair, mouth ulcers, abnormal and excessive menstrual bleeding. There are so many causes. What are the causes which involve your circulatory system? Anemia reduces blood viscosity, right, due to decreased red blood cell. Then decreased systemic vascularization due to enhanced nitric oxide mediated vasodilation. Then low blood pressure causes neurohormonal activation. What is the ACD? Anemia of chronic diseases. Okay. Then so many viruses which can cause anemia. These are the linked to apoptotic anemia and hepatitis, Epstein-Barr, cytomegalovirus, paravirus, B12, and HIV. These are the causes of anemia which can involve all the system. Anemia is the most common hematological abnormality seen in systemic disorder. Okay, thank you. Now, what question I have to ask to the expert that have been asked by Aparna? What is the limit for the routine patient? What are the limit of hemoglobin? We can accept the patient for the routine surgical patient.
Experts.
Elective surgery.
Yeah.
We can very well manage a patient with 7 gram% of the hemoglobin in, but we can accept for routine surgery. We ask for the around 9 or 10 gram%. Is it correct or not?
Dr. Bala Bhaskar sir has joined. Welcome,
Yes.
sir.
Welcome, sir. Welcome, sir.
Sorry, I joined late, but I just heard the question. You want me to respond?
Yes, sir.
Yes, sir. Yes, sir. Yes, sir.
Yeah. So ideally, there have been some changes in the last 10 years. We have come back to more conservative values nowadays. So if you think in terms of a regular routine surgery, so I think it is 10 gram% and upwards of 10 gram%. So basically, so we should not be thinking in terms of I accepted 9 grams, there are no problems, and with renal failure, CRF, as sir was telling. So even in CRF, it's always advisable to target higher levels of hemoglobin rather than speak about 7 grams, 8 grams, or 9 grams. Maybe 10 grams and up for a normal patient, and at least 9 grams and up towards 10 for CRF patients also. That's a broad consensus among different guidelines in general.
Yeah. Yes, sir. These are the guidelines we know, but we are working. Our city branch is working in rural area.
Yes.
Where patients are very poor.
Yeah.
So hemoglobin levels are very low.
Would be low.
Hardly we get patient of 10 HB, sir.
Yes.
That's true.
Nutritional problem or something like that.
Yes, sir.
So I do understand, and that's a compensation. See, all of us know. So many of you are our own senior colleagues who are active in private practice, and we do have this set of population compensation, as I heard you telling, in terms of the cardiovascular system, in terms of the blood itself. So there is dilutional anemia, but it doesn't cause that much of harm. Number one, it still helps to deliver the oxygen to the tissues at the level of the cellular level, and number two, that the resistance to flow also comes down. And if indeed the patient loses blood, what the patient is losing is a diluted blood. So that way, some sort of protection is always available. So, but even I do attend to some private cases. I have been attending for last 30 years. So it is advisable nowadays because of the medico-legal issues. We take a second look. For example, I would have happily done a case with 8 gram percent even for a regular hysterectomy, and even in medical college, in my college, we still have patients who come with 5 grams percent for bleeding piles, as you say, hemorrhoids.
Yeah.
Okay, so those things still happen, but the level of assessment and preparation from our side are expected to be slightly better at least. So
We have blood in hand. Can we accept the patient at 8 or 9? Like with blood in hand and no ECG changes, that is no compensatory changes.
For
Yeah.
Can
elective
we
or
take the
emergency?
patient? Yeah. For elective as well, if the patient's HB is 9.
Yeah.
And if in private practice, I'm saying, if the surgeon is insisting blood is there and no ECG changes, patient is not very aged. So if there are no other risk factors, and if only HB is 9 or for that matter 8.5, in between 8 and 9, and we have blood as well, then can we proceed with anesthesia? I mean, just what is your thought?
So you want me to
I'm not
respond?
asking about any guidelines. Yes, but what is your opinion, like as an expert?
We have to go beyond the guidelines because guidelines are after
Yes.
all guidelines. So it's
Yes,
not,
yes.
there is no mandatoriness in many of the guidelines, but it will help
Yes.
us, it will guide us in practice, and it
Yes.
might help us, definitely not might, it helps us in case of any litigations. So they mention
Okay.
the common thing which you must do, but if you are not able to do, if you are very confident of defending it in court of law, there is no issue.
Yes, yes.
That's never a
Medico legally,
problem.
it's okay.
Yeah.
Yes, yes.
It's okay.
Because
So
you can have lab errors also. A patient
Yeah.
with 9 HB, sometimes a lab can show 10.
Yeah.
So on paper, if it is 10, but clinically patient is 10, we can take about. Clinically, I am finding that the patient's HB on paper is 10, but
Yeah.
clinically patient is not very much. I mean, if patient is pale, there are changes, ECG changes are there. Then should I accept?
Yeah, I understand. Definitely understand. You
Yes,
get
yes.
lower values from between the laboratories, and on the opposite
Yes,
side,
yes.
you've got long-term hemo concentration sometimes. Some of the patients, falsely higher levels will be seen. So
Yes,
that
yes.
happens. But coming back to your question, when you said patient is got just around 8 to 9 and comfortable, even attending,
Yes, yes.
attending to his or her work, overall able to maintain her daily routine. So
Mhm.
depends upon the invasiveness of the procedure and your anticipated blood loss in the patient. So no cardiac comorbidity, and if you there is no ongoing blood loss, number one, basically,
Mhm.
and
So only medical legal concern, only if you keep that aside, then you can go, right? You
yeah,
can proceed with the surgery.
and second, one small factor, I would also want opinion from our senior colleagues. So
Yes.
blood in hand, when you say blood in hand, I would want it to be cross-matched for some cases. See,
Let's say everything is
yeah,
done. Everything is done.
everything is done.
Cross-match blood in
Cross-matched and
hand.
kept ready.
Yes.
Not that I
Yes,
send
yes.
blood sample at the end, then
No, not reserved, not reserved.
Not
It's
reserved.
ready with cross-matched and ready to give to the patient.
That's
That way,
important.
if it is available, then can we proceed? I mean, just a expert opinion I'm asking.
I don't think
Because this point may help in various private practitioners. Because many a times we
Madam,
face
I
this
agree. I think
situation.
you can, in this situation, you can go ahead. I don't think there should
Okay.
be any problem.
Yeah.
Okay. Thank you, sir.
It is always better to have a blood in hand in this patient, but you have to expect how much blood loss will be there intraoperatively. That you have to consider.
Yeah. Now I do see some topic. Sorry if I am wrong. There is a topic related to TRP also.
Yeah.
So there are some cases, where you indeed expect some, if it is a bigger gland, and if unfortunately our urology colleague is slow and they are using
Yes, sir.
monopolar, so there is always a risk of
Yes, sir.
loss and other things. So
Yes.
those are the cases
Always.
which will be definitely be inclining towards getting the blood. You see the red bag on the table.
Yes.
Yeah.
That's
Yes.
important.
So it always outweigh the risk reward.
That's
Yeah.
important.
Okay. Thank you. Thank you, sir. Thank you.
Thank
Yes,
you.
sir.
Thank you very much.
So to proceed with now, till now we came to that anemia should be viewed as a serious and treatable medical condition rather than a simply laboratory value, right, sir? So our next speaker for today's webinar is Dr. Arshad Sheikh. Yes, sir. Sir. CBT, sir.
No, carry on.
Okay, sir. So, for the next speaker for today's webinar is Dr. Arshad Sheikh, who is working as a senior anesthetist in Worli city since 20 years. He is a practicing anesthesiologist, an accredited EMMC speaker, and a lifestyle coach. So his next topic is blood transfusion protocols. So over to you, Arshad, sir.
Thank you, Sachin. Am I loud and clear?
Yeah, you are, sir.
Okay, thank you. I am really very excited today. Good evening, everybody. I welcome you all on this session. I'm really excited to be presenting my topic in front of so many dignitaries. Dr. Diwatiya sir, Dr. Sukhminder Singh, Dr. Pankaj Gupta sir, and all other ones. And I'm really thankful to my friends, Dr. Assegaonkar Balaji and Dr. Rajesh Tagadpalle for making all these webinars possible for us in these peripheral branches. Paradi. And I'm really thankful for Dr. Shilpa Tivaskar madam for her efforts to make today's webinar possible. Dr. Tarkase sir, my teacher, Dr. Aparna Kulkarni madam, and all Ambajogai team, as well as my colleagues, Dr. L.D. Lohia and Sachin. I'm really sorry for my camera, it is not working. So I will be only just presenting my presentation. So I welcome you all for today's talk on blood management. I'm really very happy to be presenting my talk in front of the original creator of this PPT, I would say, Dr. Bala Bhaskar sir, because many of the ideas and slides I have taken from his lecture only. So we all know, friends, bleeding is a natural outcome of majority of surgeries. But the good thing is that not every surgery and every time blood transfusion is needed, because our body has an excellent compensation for decrease in HB. It decreases the viscosity so that the resistance and flow of the blood to the tissues and organs increases. It increases the cardiac output, increases the O2 extraction by increasing the sympathetic drive. But if sometimes the bleeding is more and acute, then it may be potentially harmful or even life-threatening, because the compensation may not be adequate or it may be too late. So, replacement of blood or blood products may be indicated. But we all know blood transfusion is never safe. Blood, when given and when needed, saves a life, but only increases the risk and cost when not. Because safety is never guaranteed. It is always associated with reactions, infections, and clerical errors. And further evidence and recommendations are against it. So the newer concept of blood transfusion is now changed to blood management. It is an evidence-based, multidisciplinary approach to optimize care of the patient who need blood transfusion. And it depends on three major pillars. First is pre-oply, to treat the anemia or to optimize the HB. During the surgery, the pillar is to minimize the blood loss. And post-operative, appropriate use of blood and or its products. The aim is to reduce the surgical risk and improve the patient outcome after surgery. Same can be said in obstetric. Antenatally, treat the anemia. Peri-delivery, minimize the blood loss, and postpartum, appropriate use of blood and its products. So the first pillar, optimize the HB or treat the anemia. Anemia, my friends, is the most common hematological problem in perioperative period. Now we were discussing about the amount of HB that we have to see. We all know we are all working in the peripheries. Rarely we get a patient above 10 or 11, especially the patient for lower LSCS. They are always below 10. So it is a major problem and decision making for us all. 1/3 of the patient undergoing elective surgery are anemic. We should be always cautious because anemia is only a symptom and it may be due to any condition that may affect the surgical outcome. And there is also a strong association between anemia, perioperative morbidity, and mortality. So treat the anemia. That is very simple. Traditionally, anemia is associated with chronic diseases and nutritional factors, as Dr. Tarkas sir had now said. And it was historically treated with blood transfusion in perioperative period. But the data suggests that anemia, it is an independent risk factor for many surgeries. And blood transfusion does not ameliorate this risk, but has been shown to increase the risk of complication and hospital length of stay. So, treat anemia. For that, we have to identify anemia and its causes. A thorough history and evaluation is very important. Bleeding such as menses, melena, symptoms related to anemia such as angina, dyspnea, fatigue, palpitations. These symptoms are very, very important to be evaluated before operations because they will give you a guideline about the compensatory state of the body of the patient. Symptoms on underlying diseases should be sought out such as malignancy, renal failure, endocrinopathies, chronic infections, liver diseases. Past history of anemia should be sought out. Treatment such as splenectomy, hemolytic disorders should be worked out. Family, social, occupational history should be given. Physical examinations such as pallor, bleeding, hepatosplenomegaly, and especially heart murmur, this should be sought out. Diagnostic evaluation depends on CBC, PS, reticulocyte count. We have to manage anticoagulant and antiplatelet therapies if the patient is on it. And you have to predict what blood loss patient is going to have for that particular surgery. Also, surgical risk factors such as age, sex, type of surgeries should be considered. And most important, surgical team now have to appreciate that anemia is a contraindication to elective surgery. Now, what level of anemia, that is a point of discussion. So managing anemia, classically it was managed by oral iron, but it was a slow process. We all know that, and associated with GI side effects. And secondly, functional iron deficiency anemia that is seen in mostly many inflammatory conditions does not take care of this. Poor viability, but still it is first line of management. Against it, IV iron therapy, now many molecules are available. They have excellent results, replacement only in single dose. Response may be seen within 5 days, but peaks may have to wait for 2 to 4 weeks. But the only side effect is it may have a serious side effect. In case of chronic kidney diseases and chemotherapy-induced anemia, we may have to use erythropoiesis stimulating agents. Of course, blood transfusion, if there is no way out, we have to use blood transfusion. That is the last resort. But now the policy is restrictive blood transfusion therapy, as was discussed earlier. Concept was first that one transfusion, no transfusion. But now it has changed drastically. I remember when I had started my practice in 1998 in my small town, Parli Vaijnath. For every hysterectomy patient, Dr. Lohia is also my colleague. We were doing all these things. For every abdominal hysterectomy case, we used to always reserve 2 points of blood for every hysterectomy patient, and we used to give that post-operatively. But slowly we changed this concept, and now it is evidence-based. So clinical assessment after every transfusion, HB check after every transfusion, and then you have to evaluate. Stable patient without active bleeding should not receive any blood transfusion. That is what we have to look for. Now, studies have shown that patient with HB 7.5 grams can be managed without blood transfusion. And I am talking about the surgeries which will not involve more than 500 ml of blood, or it is less than 2 hours. This reduces transfusion rates as well as economics. The second important pillar is to reduce the blood loss, that is intraoperative. Anesthesia principle that we are using for this is hypotension. This hypotension may be central neural blockade, especially spinal anesthesia, but it should be risked about the sudden hypotension. So it causes sympathetic block causing hypotension, and patient positioning is very important. It should maintain the venous drainage. Hypotensive controlled anesthesia with volatile anesthetics, controlled ventilation, they also work well. Balance should be against the risk of organ perfusion. So mean arterial pressure should be maintained 50 to 60. Always we should be cautious in compensatory cases such as coronary artery disease, cerebrovascular accidents cases, and uncontrolled hypertension. Pro-hemostatic agents such as tranexamic acid, it is an anti-fibrinolytic agent which inhibits plasminogen activation and provides clot stabilization, thus reducing the blood loss and reducing the blood transfusion. So it has been shown to decrease blood transfusion by 1/3 of the patients in all surgeries. And this percentage goes on in orthopedic surgeries. So excellent drug to be used now. Can be given IV, intraocular, oral, and so many on. Weight adjusted doses of 10 to 20 milligram per kg can be repeated during intra-op and post-op period. So it is very safe, cheap, effective. Routine use is advocated if blood loss anticipated is less than 500 ml. So that is the UK recommendation. It may be associated with a rare complication, that is post-op seizure. Second important is acute normovolumic hemodilution. In this, the patient's own blood, should be taken before scalpel, starting of the surgery. And the patient should be on euvolemia maintained by crystalloids or colloids. And the blood that is withdrawn before surgery should be given after surgery. And we all know it is as good as the whole blood, but here we should be very cautious about the patients who are on compensatory ones. Other strategies may be used in acute or emergency cases in trauma patients on antiplatelets, acquired platelet dysfunctions due to drugs such as uremia. So desmopressin is a very good drug to be used. Procoagulant factors such as prothrombin complex concentrates, fibrinogen concentrates may be used as and when required. Also, vasculoelastic hemostatic assays now available, where they are very helpful. We should avoid this lethal triad of hypothermia, coagulopathy, and severe blood loss. Surgical principles, these includes timely surgery when the hematological tests are optimized. That is the first and foremost thing that we should do. Other things to decrease the blood loss, tourniquets should be used wherever feasible. We should avoid drains. We should use rigorous hemostasis using diathermy and scalpels now available. Minimum invasive surgeries such as robotics, laparoscopy, blood salvage system, very important nowadays, and it is now modern blood salvage systems are very good. They can be used intra-op as well as post-op. Topical agents, vasopressin injections, local anesthetics with adrenaline, these all things can decrease the intra-op blood loss. And the last pillar is post-operative. Post-operative, the policy is very clear, restrictive blood transfusion policy. Other things which may be used to stimulate erythropoiesis in case wherever required, avoid drugs and incidents causing anemia, be vigilant for post-op bleeding, maintain normothermia, manage anticoagulation, treat infections promptly, post-cell salvage, as I had already said, minimum oxygen consumption, reduce the frequency and volume of blood for blood tests. This is very important and should be always underlined. Iatrogenic anemia. Nutrition, iron, vitamin supplementation, avoid secondary hemorrhage. Warning measures can be used in postoperative period. Prophylaxis for GI bleeding should always be given. And these are all important. As we all know, we as an anesthetist, they are physicians for surgeons and surgeons for physicians. So very important our role. It is dynamic. We have to all balance all these activities. And this is a beautiful chart where we can see the pre-op, intra-op, and post-operative, what we have to do. So concluding, identification and management of high-risk patients, very important. Optimization of red cell mass, that is the first and foremost thing that we have to do. Timely, meticulous surgical and anesthesia techniques to reduce the intra-op blood loss, and post-operative vigilance and restrictive blood transfusion therapy is very important. So that was all about from my side. Thank you very much.
Any questions to the experts, Arshad sir? Very nice presentation.
Thank you,
Very nice.
Sushil.
Bajwa sir wants to say something.
Sir.
Bajwa sir.
I think we will be asking at the end of the sessions of the entire this one.
Okay. Okay, sir.
Or it's require the question to be asked here.
Yeah, that's what I asked Arshad sir. Does he has any questions towards experts?
I don't think so, because whatever he has explained is very practical, feasible, and the more of the anemia is it has to be made aware by the practitioners basically.
Yeah, definitely. Sir.
Because when you are dealing with patients coming to the periphery, they are invariably having the anemia, especially the pregnant patients, if you see.
Definitely. Yes.
And the most important is not the CBC count, whatever the hemoglobin you get on the blood count, whatever the laboratory values you get. It's about the hematocrit.
Yeah.
It's about the clinical acumen of yours, how you examine the patient. It's about the clinical, the profile of the patient, how the patient really behaves in the normal life, the pathophysiology, about the activities, the tiredness, and all those symptoms are very, very important. Sometimes, even in the many of the females who are using the haldi, the turmeric powder, they may not be able to see the pallor in their palms. Sometimes even the sclera is not that much well colored. The different diseases are there. So you may not be able to correlate the values of the laboratories with the clinical examination. So I think it's history taking is very important, but the patients in the periphery, they don't give you much time. When especially in the patient on the table and you are saying that generally the patient has to be taken up for the surgery. I think the anesthesiologist has to put a foot down when the requirement is there, when he sees that requirement is very much there and you cannot afford to give anesthesia to a patient, because during surgical, you have to evaluate how much loss can be there. Over the years, you come with that much experience. So I think definitely anemia plays a very major role, but rightly said by Dr. Arshad, it's a very much treatable and clinically very much, reversible condition, even on the operation table also. I think he has covered almost everything, whatever is required. So good talk by Dr. Arshad, and
Thank you. Thank you, sir. Thank you.
Lawyer sir, may I make a comment? Dr. Devatia.
No, sir.
Yes, sir.
So again, I must compliment Dr. Arshad for introducing the concept of patient blood management rather than just transfusion.
Thank you. Thank you, sir.
So like he mentioned, intravenous iron is very good. And one more thing we need to consider in many of our patients, if you look at their CBC, if their MCV is high or their MCHC is high, then they may often require B12 and folic acid.
Yeah.
So you just need to have one more thing that you need to check before the surgery. I just want to introduce a small note of caution when you're looking at hypotensive technique in anemic patients, especially elderly anemic patients, because surgeons they will never think the bleeding is because of them. They will think the bleeding is because of us.
Yeah.
So they will say drop the blood pressure, but whatever we do to drop the blood pressure, we vasodilate, and second we depress the heart, depending on what drugs we are using.
Yes.
And in a patient who's anemic, say whose hemoglobin is 7.5 or 8, his cardiac output is, the oxygen delivery is half. And if in that situation you drop the cardiac output because of the drugs you use to promote hypotension or hypotensive anesthesia, even to a MAP of 50 or 60, then it may have an impact on the total patient population. So just a small note of caution in anemic patients, unless it's really critical, simple things like he mentioned, like maintaining posture, encouraging venous drainage, of patent airway, good positioning, all those things actually help reduce blood loss quite well, rather than trying to hope for a very low blood pressure. And say ANH or acute normovolemic elution works best when the hemoglobin is above 12, because then you can take out 1 to 2 pints of blood, and replace it. In someone whose hemoglobin is 8, you're unlikely to be able to take out any blood because the target hemoglobin, when you look at normovolemic hemodilution, is about 8, 8 or 9, something like that. So while they are good to prevent blood loss in other situations, in anemic patients, you have to be a little careful. That's the only point I want to say.
Thank you, sir.
Hello. Thank you very much, sir, for your encouraging comments and encouraging us living in the periphery for these webinars and activities. Thank you very much, sir.
Thank you, sir. So, at last, the need of the hour is to standardize our protocols for the assessment of anemia and perioperative workup for the patients. So, to present the next topic, I invite again Dr. Aparna Kulkarni, madam, and her topic is hemoglobinopathies. So, over to you, madam. Madam, unmute yourself.
Thank you, Sachin sir. And after this common topic of when to transfuse, how much to transfuse and all, let's deal with some rare diseases which are the cause for anemia. These are rare, but they can be a nightmare, and therefore they have to be managed properly. And these are nothing but hemoglobinopathies. So hemoglobinopathies are wrong. Just a minute. Is it seen?
Yeah, but make it full screen.
It's full screen only, ma'am.
Go to presentation, madam. Make it a full screen.
We are not able to see it as full screen.
This is full screen only. Actually.
Madam, right.
Yes.
Okay. So, hemoglobinopathies are nothing but diseases involving abnormalities in the structure or production of hemoglobin. That is, as you all know, that hemoglobin is made of 2 alpha and 2 non-alpha chains. So, in adults, they are beta chains, but it can be gamma, delta, or epsilon. That is fetal hemoglobin, or it can be HbA2, or it can be other types, that is embryonic hemoglobin. So, when the other 2 chains are replaced by some abnormal chains, then you get diseases called as hemoglobinopathies. Now, mostly encountered hemoglobinopathies are sickle cell disease, thalassemias, and dyshemoglobinemias. Now, why we are concerned with hemoglobinopathies? This is because the oxygen which is transported to the tissues, this is mainly carried in maximum amount bound to the hemoglobin. And therefore, if these are abnormal, then the oxygen transport to the tissues will be abnormal, which will result in tissue hypoxia. Also, another important thing which is concerned is the nitric oxide transport. Many of them, they know that only oxygen is transported by bound to hemoglobin. But the other important factor, that is nitric oxide, which is important in maintaining the vascular integrity. That is, nitric oxide plays an important role in vascular remodeling, endothelial activation. And therefore, this nitric oxide transport is also disrupted if there is a hemoglobinopathy or abnormal hemoglobin. So, abnormal hemoglobin poses a problem of hypoxia because of lack of oxygen to the tissues as well as disruption in the vascular integrity. So first deal with the sickle cell disease. This is the most commonest encountered hemoglobinopathy. What is the problem? There is an abnormality or point mutation. It is guanine, adenine, guanine for guanine, thymine, guanine. That is resulting in production of HbS, that is sickle cell hemoglobin. It can be heterozygous or homozygous. That can be a carrier state or a disease state. Now, what is the problem with this HbS, that is sickle cell hemoglobin? This hemoglobin is very unstable and it degrades rapidly. So there is precipitation and polymerization of hemoglobin, and this leads to deformation of the cell, and you get a typical sickle cell. So this process leads to decreased hemoglobin in the patient, as well as the hemoglobin degrades, there is release of free iron in the solution, which consumes the nitric oxide, and therefore there is a state of nitric oxide deficiency in these patients. This leads to chronic inflammatory vasculopathy. So in these patients, only anemia is not concerned, but there is a vasculopathy which causes various complications in these patients. What are the various complications in these patients? They have a short lifespan of RBC leading to, because of hemolysis, there is chronic hemolytic anemia, and because of the vasculopathy, there is vaso-occlusive crisis and there is acute chest syndrome. So what is this vaso-occlusive crisis? There is bone pain due to marrow infarction of lumbar spine, femoral shaft, knee. Also, there can be abdominal pain due to GI dysfunction, splenic or liver infarction. There can be acute chest syndrome, that is, there is acute lung injury, which is diagnosed as new pulmonary infiltrates involving at least one lung segment on chest X-ray, along with chest pain, fever, tachypnea, wheezing, and cough. So these patients can be posted for various common surgical procedures, like for in abdominal, you can have cholecystectomy, splenectomy, appendicectomy. In cardiac, for bypass or valve repairs, pulmonary thrombectomy. In neurological, there can be intracerebral aneurysm ablation. In obs-gynae, there can be routine procedures like LSTS, hysterectomy, dilatation, curettage, tubal ligation. In orthopedic, they can be posted for hip arthroplasty, that is vascular necrosis, or there can be drainage of bone infections. So these are the common procedures for which you can get a patient of sickle cell disease. Now, what is important is, again, the same procedure. First, you have to do a thorough preoperative assessment of the patient. For that, you have to confirm the diagnosis of the patient, thorough history and examination with respect to the extent of anemia. As I already said, the compensatory changes because of anemia, as well as the various factors which the patient can be precipitated to complications of sickle cell anemia. That is, whether the patient had any previous episodes of exacerbations, what is the pattern of exacerbation, what was the severity of exacerbation. So this all has to be narrated from the, or it has to be taken from the patient. Then along with that, a proper thorough history and examination of the patient has to be done with respect to the degree of anemia, various compensatory changes, and you have to have proper assessment of the various major organs like lung, brain, kidneys to evaluate the end organ damage which is caused by the sickle cell anemia, because the vasculopathy also causes various changes in the various important organs, and therefore that has to be also assessed. And any evidence of end organ damage has to be documented before anesthetizing these patients. It has been said that assessing HbS levels preoperatively has a very little role. That is, by just assessing the HbS levels, we cannot predict the severity of the disease. So this is not indicated in the preoperative assessment. Now, what should be the management principles in these patients? First of all, you have to have a proper hydration in these patients, because dehydration is, these patients have any intracellular dehydration, any pathologic dehydration can lead to hemoglobin S polymerization, and therefore hydration has to be maintained. For that, you should not keep these patients prolonged NBM. At least clear fluids, what ISA guidelines says that you can keep clear fluids 2 to 4 hours before surgery. So you can start clear fluids. You can give the patient clear fluids before surgery 2 to 4 hours. Or you can start mild minimum doses of hypotonic fluids. It has been found that normal saline has osmolarity of 308 milliosmoles per liter, and that can cause increase in the viscosity of the blood. Therefore, hypotonic fluids are preferred than normal saline. But be cautious that you should never cause fluid overload also, because fluid overload again can lead to pulmonary edema and it can precipitate acute chest syndrome. So judicious use of fluid to avoid dehydration and avoid overhydration. Then what should be the guidelines for transfusion? Sickle cell patients, usually they have to be maintained, blood, the HB levels should be maintained at around near about 10. So you should never go for over transfusion for over correction of anemia, and also you should never keep the patient very anemic. So you should keep the HB levels in between 9 to 10 grams per cent. Replacement of the blood loss has to be individualized based on the patient's baseline hematocrit, organ pathology, and surgical loss. Also, these patients, whenever you are planning for blood transfusion, extensive cross-matching has to be done in these patients. This is because these patients have to be screened for minor blood groups, because they have a high incidence of alloimmunization, and this can lead to fatal hemolytic reactions. So blood transfusion has to be taken with a proper care in these patients. Now, next point is you have to maintain a proper oxygenation of these patients, because hypoxia is a major trigger, and that can again lead to polymerization and precipitation. and therefore hypoxia has to be avoided, but excessive oxygenation is to be avoided. So everything has a very fine line in between the two factors in managing these patients. You should not allow hypoxia also, but if the saturation is normal, then extra oxygenation has to be avoided. Some anesthetists, they just give prophylactic oxygenation, so that is not advisable in these patients. And many a times pulse oximetry is not reliable in these patients because they have uh, high concentration of coexisting other other problems like methemoglobinemia along with sickle cell anemia. They can be in hand. So therefore, many a times pulse oximetry is not reliable in these patients. We should also rely on some other measures for assessing the oxygen saturation. Next point in management is thermoregulation. Hypothermia has to be avoided in these patients because hypothermia, it causes reflex vasoconstriction, which can increase the capillary transit time and cause red cell sludging. So this can again precipitate the various complications. Therefore, temperature regulation is of very important in these patients. Also, acid-base regulation has to be done, but it has been found that very minimal changes in the acid-base values, they do not precipitate the complications. Major changes in the acid-base values, they can precipitate complications. So mild acidosis can be tolerated, but you have to be very cautious if the patient has history of any exacerbations. In that case, you should always have a proper monitoring of these values so that the patient may not land in acidosis. Now, what are the various anesthetic techniques you can use in these patients? You can go for general anesthesia as well as you can go for regional anesthesia. There is no rule of thumb like in sickle cell disease. You should you should use this type of anesthesia. You have to outweigh the risk of each anesthesia depending on the condition of the patient and the type of surgery. But you have to take some proper precautions while anesthetizing the patients. What are they? You should always minimize the hypoxia. You should prevent acidosis, prevent hypercapnia, hypothermia, and hypovolemia. So these are the guidelines. Principles you can manage with whatever technique you have. Also, you have to be very careful in positioning the patient because normal positioning can lead to stasis of blood and that can lead to, again, precipitation of the complications. Respiratory depressants have to be avoided because that will lead to hypoxia in the post-operative period. Halothane has got a lowest risk of perioperative atelectasis. So if you are using volatile anesthetics, halothane is preferred in these patients. General anesthesia versus regional, I said it is always debatable. You have to always decide depending on the condition of the patient. Regional anesthesia has got a problem of regional hypoperfusion, venous stasis, and lack of control of ventilation. So you should always think of these factors before choosing regional anesthesia in these patients. If you are planning for general anesthesia, if you are planning for some abdominal surgeries, then laparoscopic procedures have to be preferred over open surgeries in these patients. There are some special considerations in these patients. Always, it has been found that use of tourniquet in sickle cell disease is controversial. Some say that tourniquet use can cause stasis of blood, which can precipitate the complications. But various studies have found that use of tourniquet did not have any major effect on the precipitation of the complications. Also, while using contrast imaging studies in these patients, you have to use modern non-ionic contrast dyes because they are beneficial in these patients because they do not precipitate complications. Also, post-operative care is important in these patients with respect to analgesia because pain again can precipitate the complications in these patients. Acute chest syndrome has to be taken care of, proper monitoring of these patients, and DVT prophylaxis is very important because they have low circulating levels of anticoagulating protein C and S. There is moderate thrombocytosis, there is decreased platelet thrombospondin levels, and there is increased levels of markers of platelet activation. So DVT prophylaxis is very important in these patients in the post-operative period. This was regarding the sickle cell disease. Now the other common hemoglobinopathy which is encountered is thalassemia. Again, it is a hemolytic anemia in which there is alpha or beta chain production is affected. The same picture, there is chronic hemolysis and there is hypoxia in these patients. There is splenomegaly and there is increased iron overload and hemochromatosis. Also, there is extramedullary erythropoiesis which is found in these patients. you can have other problems of hemoglobinopathies like dyshemoglobinemia, in which you have some abnormal hemoglobins like methemoglobin, carboxyhemoglobin, self-hemoglobin. Problems of interpretation of pulse oximetry in these patients is very difficult. So you should always have other measures of monitoring like co-oximetry. Co-oximetry, they have different absorption spectra or oxygen affinities. So calculation of oxygen saturation is very difficult with single pulse oximetry, and therefore co-oximetry has to be opted, in which you have different types of waveforms. Other alternative monitoring has to be adopted for assessing the oxygen saturation. Now, in methemoglobinemia, you have to avoid few drugs like acetaminophen, fentanyl, phenobarbital, and lidocaine. And the treatment, if at all there is methemoglobinemia, you have to treat it with 1 to 2 milligrams per kg of methylene blue. So in thalassemias and dyshemoglobinemia, all the problems same like in sickle cell disease. You have to manage according to the same principles. But the other important point in thalassemia is these patients may have a problem of difficult airway because of thalassemic phases. They can have difficult airway problems, and that has to be taken care of in the preoperative assessment, so that you can be prepared for managing difficult airway. Thank you.
Hello.
Good presentation.
This
Yeah.
was regarding.
It was a very vast topic to cover, but within a short span of time, covered the major questions which were related to this hemoglobinopathies. So,
Yes.
any questions towards experts, ma'am?
Whether
I have
science
a
office bearers also want to comment anything?
yes.
Rajesh sir is there. Balaji sir is there. Dr. Rajesh sir.
Any views from the experts, any new comments from the experts regarding what all points I have told? You can always contradict those points. I mean, everyone has some practical this also knowledge. So whatever points I said, like we usually don't encounter these patients. I have
Yes.
never myself treated the patient of sickle cell disease. So it was basically a theoretical discussion from my point of view. So many a times you must have faced these types of patients. My question to the experts. So what is your view regarding the tourniquet use? As I said that it is controversial. So what should be done? In orthopedic surgeries, should we use tourniquet or we shouldn't?
Experts?
Sir, my question to the experts.
Yeah, madam, I'm as much of an expert in this field as you are. I've got my total experience of sickle cell is 0. So I cannot really answer.
Anybody from the area that is
Yes, anybody who has managed these cases, or for that matter, any hemoglobinopathies.
Yeah, because it is.
So if at all we encounter such case, then what should be our what to say rule? No, that you should know.
Balabaskar sir is online.
Yes.
Sorry, no. I have not managed patients for a fracture. So definitely we have had children coming for incidental surgeries with the thalassemias. That's a commonplace. Commonplace means it is the most frequent one, number one. And number two, there have been probably, I can say I only attended not a frank sickle cell anemia. Again, there are all more latent forms of sickle cell anemia. So what we always used to do was definitely keep in mind the level of hemoglobin that the patient has got, especially in thalassemia groups. And secondly, the associated clinical manifestations in these patients. Okay, and we always referred it to the neonatologists and the pediatricians, and we would optimize the patient before the surgery is being done. And just managing the oxygen delivery, as usual, which we know, maintain the blood pressure, the perfusion part, maintaining the oxygenation, mainly depending upon the CO2 aspect. And only in the post-operative period, only one or the patients, probably 8 to 10, we had to do some EBG for the patient because there was fluid overload. So otherwise, clearly being managing the patient where there is a great risk of bleeding, That has not been done from my side also. But the basic teaching is, yes, try to avoid conditions that will create hypoxia. Okay, try to maintain the usual flow as much as possible, especially in thalassemias, in terms of maintenance of the blood pressure, and see that there is no acidosis. So these are the basic concepts. And of course, if indeed there is risk of or presence of or potential for sepsis and all in this age group, we should be very careful. So this much is my opinion. I go with Divetia sir. These are the cases. Just to conclude, onco centers where there is surgical pediatric patients, especially not the adult patients, they have better exposure. And normally, luckily, we don't manage them in the periphery also. That's one of the major considerations here.
I
Thank
think
you.
Parna madam has something to say. She has raised hands. Parna madam.
Yeah. So my comment is regarding it's in general. I just want to make a comment that nowadays we are getting a lot of patients with history of melena because of increased use of antiplatelet drugs. So these patients, they come with a hemoglobin of 5 and 6, and they are on antiplatelet drugs, and they mainly come for colonoscopy and OGD scopy. So even though these procedures are very small, and these patients are mainly cardiac patients, and that's why they are on antiplatelet drugs like ecosprin, clopidogrel. So we have to give them blood transfusion to optimize them before taking up even for these small procedures like OGD and colonoscopy. So we are giving a lot of blood transfusion to these patients just to optimize them, though the procedure is very small. So just a comment.
Thank you, ma'am. Thanks for your guidance. Yes. My question to the experts is, in case of sickle cell disease, should we always have a blood in hand before anesthetizing these patients? Or should we outweigh the risk depending on the condition and the type of surgery? Question to the experts.
Yeah, I think what Dr. Aparna, what Dr. Balabhaskar sir concluded, like depending upon the patient and what surgery it is. So maybe now since we have 6 cases left, can we just have cases one by one and then the panel?
Yes. Yes, we can start with the cases.
Already
Only
8
small
o'clock.
remark.
Yeah.
Only small remark in brief I can make is,
yes.
Of course, we should also be thinking in terms of some immediate investigations or point of care investigations if possible. That will help us in maintaining these patients better. Okay, so to the extent if it is a higher center, so we can indeed have an active interaction, send a blood sample at the moment where there is you think there is need for blood transfusion. Okay, so if it is a major surgery, so and to the extent like something like TEG and all would be needed in some cases. So one advent recently is the point of care testing, which we were not discussing 10 years ago. That you have to keep in mind. Thank you.
Madam, I just wanted to make one quick comment about methemoglobinemia. It is very often drug induced, and some drugs like nitrates, sulfone, especially dapsone. Now, in the past, if patients used to take dapsone for leprosy, for Hansen's disease, and if they came up, and you recognize methemoglobinemia because your saturation is low, okay, but your PO2 will be normal. Run up PO2, PO will be higher, but the low. The other dangerous thing about methemoglobinemia is that, even if your methemoglobinemia percentage is say 15, 20, 30, your oxygen saturation will stabilize at about 85%.
Yes,
so,
yes.
But then if your methemoglobin level is 30%, then actually your oxyhemoglobin is only 70%. But you think it's 85%, which is not so bad. So that is a worry about methemoglobin. So, but it's nice to suspect methemoglobin if your saturation is low and there's no apparent reason. Everything seems to be okay. Healthy, fit patient, good lungs, circuit okay, oxygen going, no issue. But your saturation showing 85, 88, 90%. And you do a blood gas and your blood gas comes on 40% oxygen, or maybe you made your PO2 100%, your FiO2 100% because the saturation is low, and it's still 85, 88%, but your PO2 then will be 400, 500, so that should make you suspect something like methemoglobin is there in your patient. And the blood is typically, like they say, dark brown in color and, all those sort of things. And like you mentioned, you need a co-oximeter to diagnose methemoglobin.
Yes, sir. Thank you, sir.
Thank you, sir.
Thank you,
So,
sir.
Aparna madam, can we proceed for the cases now?
Yes. Now, after this discussion, we'll be having a few case presentations. The first case presentation will be done by Dr. Ganesh Kandarkar. He's an assistant professor at SRTR Medical College, Ambezogai, and he'll be presenting a case in which the diagnosis is the patient of 6.5 grams hemoglobin for colonoscopy. So this was very commonly encountered case. He'll be elaborating about this. So I request Dr. Ganesh Kandarkar sir to please narrate his case.
Okay. Hello. Good evening, all my honorable, all my seniors, colleagues. Today I am going to present the case of anemic patient for colonoscopy. A 50-year male with complaint of abdominal pain and rectal bleeding since last six months posted for colonoscopy. Patient had history of breathlessness and easy fatigability on daily work since last 2 months, and since last 1 week, patient had history of heavy bleeding. There is no previous significant medical or surgical illness. On examination, patient's disease fear, conscious oriented, pulse rate is around 110 per minute, BP is 110-70 millimeter of mercury. On systemic examination, RS, ear entry equal on both sides, CVS, there is no murmur, S1, S2 is normal. Patient is clinically pale. Area assessment done. Hello. Area assessment is done. Area assessment done. It is normal. On investigation, patient HB was 6.5 gram. Platelet count was normal. PT INR was done. PT around 30. INR was around 1.35. PT INR was done to rule out any bleeding diathesis. ECG showing sinus tachycardia. In my case, 5 we did anesthesia or analgesia during colonoscopy, as there is a pain due to stretching of bowel and mesenterium due to the loop formation of instrument. To relieve the pain, we need to give an analgesia or anesthesia. In my case, there is emergency procedure because patient had history of severe bleeding in last 1 week. So, patient is posted for the diagnostic colonoscopy. Patient may have polyp or CA colon or any IBS also. In our center, one PCO was issued. Patient taken inside the OT. All monitors attached. IV access taken to the patient. Then patient given benzodiazepines in the form of midazolam 1 mg. Before that, we give injection ondansetron 4 milligram, then pantoprazole 40 milligram, then injection midazolam 1 mg, and then fentanyl 1 milligram per kg. O2 given by Fentima to the patient at 4 liters per minute. Intraoperatively, patient is stable. Patient didn't complain during the whole procedure. Procedure completed within the 20 minutes, and after the completion of the procedure, patient was conscious and oriented. That procedure was of short duration of 20 minutes. Procedure was uneventful. In our institute, we generally do the cases under mild or moderate sedation or deep sedation with monitory anesthesia care by using propofol or ketamine. Now I have some query to the expert. What is the ideal anesthesia for colonoscopy in severe anemic patient, and what they use at their own institute?
Expert, can anybody answer his query?
My query is, what is the ideal anesthesia for colonoscopy in severe anemic patient, and what you use at your own?
So I can give just 2 points to be conveyed here. So if you feel, as you say, there is otherwise no issues. Ketamine as a drug in any combination will be encouraged. Okay, so it could be something like ketofol. It could be like the thiopentone also. If some of us old timers we talk about it also, that's okay. And we have got, for example, nowadays dexmedetomidine which is available, provided
Yeah.
you are sure that the patient would not have a precipitated hypotension. If
Okay.
there is a bleed, there's a bleeding growth inside during colonoscopy. Okay, but any careful administration of any of the drugs like balanced anesthesia. So because I think there will be difficulty in mobilizing opioids in the periphery. Okay, if indeed you have got fentanyl, you can have a combination of fentanyl plus dexmedetomidine or ketamine.
Dexmed.
These three would be as a very beautiful balanced analgesia and a light anesthesia for a particular patient. So that's always advantage. And generally, airway is better maintained in terms of course, we are not doing anything, but the airway reflexes or the pharyngeal reflexes, when indeed there is an emergency requirement, okay, that way there is always a favorable usage of this combination. So opioids ideally are not used. And in the institution, when you talked about institution, so we are happy with ketofol, fentanyl with ketofol. Okay. So that advantage is always there. And beneficial, you can do it even in the private practice.
Okay. Sir, I have one more question. Do we ask surgeon to build up HB up to 7.5 over HB, or we can continue with the same as 6.5? Whether we have to transpose the patient before taking to the diagnostic colonoscopy?
Yeah. So when you go back to the so-called the guidelines and evidences, so there are evidences for about 8 to 10 different clinical scenarios, including something like you have mentioned. So there, one standard that is often quoted is 7.5 gram %, basically.
Okay.
So you see that you build up to 7.5 gram % with an ongoing blood loss.
Okay.
These type of cases. So most likely they are onco cases only. There would be risk of continued blood loss, and they say at least 7.5 gram.
Okay.
Okay. So that depends upon your assessment of the patient. As usual, go back to the cardiovascular stability of the patient. Okay. And whether efforts have been made to see that anemia is corrected. That is, no, there are preoperatively anemia correction is one factor, right? So that's very important in these patients. And still you can keep in mind use of some antifibrinolytics also.
Okay.
So Dr. Asher also spoke about tranexamic acid being used in the preoperative period. That also is a very good drug which is grossly underused in our private practice, which I am trying to tell. Thank you.
Thank you, sir.
Thank you, sir, for your guidance. And thank you, Dr. Ganesh Khandarkar, sir, for this case. Now, the next case will be presented by Dr. Mahesh Sopade. He is also assistant professor at SRTR Medical College, Ambezugai, and he will be presenting a case for patient with hemoglobin 7.5 grams posted for laparoscopic or open hysterectomy, which we usually face. This is the commonest case which is usually faced by all the private practitioners. I request Dr. Mahesh Chopade, sir, to present his case.
Good evening, ma'am. Good evening, all seniors and my colleagues. I will present a case of anemic patient posted for laparoscopic hysterectomy. In short, so our patient is 45 years old female, which is housewife. Came with chief complaint of PV bleeding since 1 year, and she has pain in abdomen since 2 months, and she has a complaint of AZ fatigability since 1 month. History wise, she has no any significant past medical and surgical history. On examination, patient is conscious, oriented. The only positive finding is pallor 2+, pallor which is 2+. Otherwise, patient is vitally stable. BP is around 120 by 74, and heart rate is around 94 beats per minute. Airway wise, patient is airway examination is not suggestive of any difficult airway. On systemic examination, patient in cardiovascular system, both heart sounds are audible, normal. There is no murmur. On respiratory system, chest is clear and air entry is equal bilaterally. In CNS examination and per abdo, patient is examination is within normal limit. Investigation wise, CBC is showing hemoglobin value of around 7.5 gram percent. The rest of the values of platelet and WBC count is normal. Patient's chest X-ray, ECG, and kidney function tests are within normal limit. So how we manage this patient at our institute is like patient was admitted on the day before surgery. So for pre-operative optimization, we asked the surgeon to transfuse 1 point of Paxay volume overnight, and we repeated the hemoglobin value in the morning, which came around 8.8 gram percent. So hemoglobin of the patient rose from 7.5 to 8.8 gram percent. So we accepted this patient at this value of hemoglobin, and we proceeded to the surgery with 1 point of PCV kept in hand reserved for any intraoperative need. So on the day of surgery in the morning, we took the patient inside the OT, and we attached all monitors and recorded all the baseline investigations. Baseline parameters. Then our plan of anesthesia was balanced general anesthesia with endotracheal intubation and mechanical ventilation. So we pre-medicated patient with glycopyrrolate, midazolam, and fentanyl, and anesthesia was induced with propofol and vacuronium as a muscle relaxant. We maintained anesthesia with inhalational agent isoflurane, and intraoperatively, patient was given a 1 gram of paracetamol as an analgesic agent. The total blood loss during the surgery was around 200 to 300 ml plus bulky uterus as a specimen. Surgery lasted for around 2 hours, and during this period, patient received 3 points of ringer lactate fluid. Then at the end of surgery, patient was extubated uneventfully and shifted to the recovery. So we asked the surgeon to repeat the hemoglobin value after 4 hours, which came around 8 gram percent. And we accepted this value. So we did not go for any further transfusion, and patient was monitored overnight in the HDU only. So I want to ask, my question is, we are doing this hysterectomy surgeries in non-acute settings. So we have some ample of time for the optimization. And these patients who are actually having a PV bleeding, they are basically suffering from iron deficiency anemia due to the bleeding. So should we wait? Should we optimize these patients with IV iron therapy, or we should go for the blood transfusion and proceed to the surgery? Hello.
Yeah, I heard. Yeah. So basic concept would remain the same.
Yes.
Whenever we have got time. So it is advisable to suggest that we optimize the preoperative hemoglobin for the patient. So that's very important, right?
Yes.
So that is anemia. Anemia has to be managed. And part two, so that's mainly related to iron. We talk more theoretically or about higher center. They also there is a possibility of adding erythropoietin also. So we'll not go into the details, but it is mainly an academic discussion. But otherwise, iron management is very important in the preoperative period in this set of patients. And already, as far as you will know, and we know that gynecologists would have given some of the drugs in the preoperative period. Iron management would have been done. Generally, we expect them to do. If they are not done, it is advisable to ask them to do, request them to do. And second thing is, apart from anemia management, it is the prevention of the blood loss. Okay, prevention of blood loss in the sense, the very fact that normally we give a spinal anesthesia or give epidural anesthesia or combined, or if it is part of a general anesthesia for the patient, so we expect a reduced blood loss per se. It's like induced hypotension and reduced blood loss intraoperatively in this set of patients. Because we talk in all huge cases, bigger cases, that there is hypotensive anesthesia and all. There is also benefit of giving spinal and epidural in these patients. Okay, because it will also induce some sort of hypotension and the surgical bleeding would come down. Is it not? So, for example, when you do cesarean section, apart from other indications, the obstetrician would complain, sir, there is a lot of bleeding and there is no, the uterus doesn't contract, spinal would have been better. So even for other surgical procedures, it's always, if the conditions allow, it becomes like a hypotensive anesthesia for the patient. Okay? That's the second thing. And the third aspect is basically I again go back to the tranexamic acid. You can have 1 gram of tranexamic acid being given to the patient. So I don't know about how many of our colleagues are using. So you can just put it in 100 ml of saline and administer that 1 gram for about 20 minutes. On an average, it is expected to reduce the bleeding significantly. Okay, at least all of us remember about 7 to 8 surgical fields, it has gained popularity. So it gained popularity initially with the obstetric practice as per the WHO. We got the woman trial, WOMAN trial. So it was initially started in Africa, then it became popular across the world and people are using. And of course, in spine surgeries, cardiac surgeries, and neurosurgeries and trauma everywhere. So that's one thing we can request if somebody is not practicing. Okay, that concept. And finally is the blood management. Blood management also, in fact, not in this case. Initially, we had given some 15 minutes option for us. One of the unusual things which is for the current period is whole blood transfusion, which was done about 20-30 years ago regularly. We only talk about the packet cells and plasma and platelets. Okay. So there is still a scope for whole blood only when there is an acute severe blood loss.
Acute blood loss.
So indication has come down. So that's the last one. I'm only adding it as a last part. Okay. So that can happen unusually. Otherwise, the routine indications, you please follow up for the packet cells for the patient and manage if necessary 1:1:1 ratio. So that is my take on this.
Sir, what is your opinion regarding whether the patient should go for a laparoscopic hysterectomy or open? If the surgeon gives you an option, you should insist on what? Like, because laparoscopic hysterectomy has got less blood loss. These patients are on borderline levels. So should we prefer laparoscopic over open? I mean, just a practical
no,
question.
Yes,
Yeah.
definitely yes. Let sir give your opinion.
Yeah, no. So I think if a good laparoscopic surgeon, by all means, laparoscopic is preferable. There's no question about it. If had laparoscopic surgeon, then forget about it. I mean, that's a different matter altogether. But as far as anemia is concerned, I agree with Balabhaskar sir. Anemia must be corrected. The question is, how do we correct the anemia? Whether we give blood transfusion or whether we give some other method like IV iron.
No, but if you prefer laparoscopy over open, in this patient, in this scenario, which would be beneficial? I'm asking you, like, given a chance, patient is the same. You are not correcting, you are having the HB of around 8 to 8.5. So if given an option, laparoscopy is always better, no?
Yes, because it's less invasive, it's less physiologically disturbing. Of course, a little bit of this thing because of pneumoperitoneum and CO2 insufflation is there, but it's nothing that's not very major
we
now.
have controlled ventilation, right? Yes.
Or experience with the laparoscopic. If the surgeon is good, I think laparoscopic is the way up.
Always preferable. Okay. Thank you,
Definitely, it should not be done under spinal anesthesia, at least for these cases.
Yeah, the choice of anesthesia should be always
general.
Yes, yes.
Because this has been topic of discussion last few years. No, some of our colleagues practice laparoscopy. I mean, laparoscopic procedures under spinal anesthesia alone.
Yes.
So that's just my.
No, but as being an institute, we usually don't do this. Yes, we do. As being an institute, we don't do it under regional. We use general anesthesia.
But in private practice, most of them are using the regional anesthesia over general anesthesia, sir. Nowadays also, they are not preferring general anesthesia. So what will be your advice to all of us to use which anesthesia exactly?
So that's the reason I gave a simple statement. Because it's a complicated situation and a controversial thing. 100%
again medical legal problems.
Yeah, all factors together, it should be should not be encouraged.
Yes.
So because
Divatiya sir wanted to say something.
Yeah. Yes.
Divatiya sir.
No. So again, if you're giving spinal or for these patients, you need to keep in mind that there is no hypotension. Because in an anemic patient, if you get hypotension under spinal, that can be detrimental. There could be respiratory depression, especially because, see, along with spinal, sometimes you'll end up giving more sedation, especially if there is some inadequate thing and a little shoulder pain. You give little you give a little propofol, you give a little Dexmed, you give a little this, and then the patient gets respiratory depression. Now, this is laparoscopic hysterectomy, so you're going to have a head-up position. You're going to have a head-low position. So then again, the chances of respiratory compromise are slightly higher. You just need to be careful and mindful of these facts. And because of that, many of us would do general anesthesia with controlled ventilation. But if you're doing spinal, you need to make sure that you're avoiding any of these sort of potential complications.
Sir, I have
Parna
one
madam has raised her hand. Parna madam.
Parna
No, I
madam
think.
wants to say something. No, I think so.
Yeah, with that previous one.
Okay, thank you.
Ma'am, I
Thank
want
you,
to,
Dr. Mahesh, sir.
ma'am,
Okay.
I
Mahesh,
have
sir
one more
has a question. Yes,
I want to
yes.
ask one more question to Divya, sir, please. Hello.
Okay, yes, you can talk.
Sir, what should be our HB value as a transfusion trigger in post-operative setting? Suppose patient is not bleeding in post-operative setting, and so what should be the what hemoglobin value should be our transfusion trigger to transfuse in post-operative settings? Suppose in this case, like patient has a hemoglobin value of 8 in post-operatively, so should we transfuse that patient or we should not? As in relation to the pre-op values of the patient.
So I think I missed a bit of your history, but I think this patient had a hemoglobin of 8 for quite some time.
So patient was having hemoglobin value of 7.5 pre-operatively.
Yeah.
And
again, if at 8, now again, don't just look at the hemoglobin value of 8. See how the patient is. Okay.
Yes.
Now, this patient may not be running around and all because she's immediate post-op, so you may not be able to get exercise tolerance. But if there is, if she's otherwise well, and let's say there is no acidosis, her blood pressure is normal, there's no tachycardia, maybe you can hold off. You just keep checking the hemoglobin every day. If you find that there is a drop, tending to drop, because what happens is the response of the body to blood loss eventually is to draw blood from the interstitium into the intravascular system. And then after 1 or 2 days, you'll find that the hemoglobin is not 8, it might be 7 or 6.5. And then maybe you might want to transfuse blood. But it's something, I won't say don't ever transfuse this patient at 8, but I'll say just watch this patient every day. If you find there is tachycardia, if you find there's hypotension, if you find there's little breathlessness, immediately transfuse. Otherwise, you check the hemoglobin, and if it comes to about 7, then I guess you're reaching your trigger to transfuse.
Thank you, sir.
Thank you, sir. Thank you, all the experts, for your guidance. Now I request Dr. Rajeshri Dhavre, madam. She is also as assistant professor at the same institute, and she'll be talking about a case of a patient who has chronic renal disease and HB of 7 grams per cent posted for TORP. I request Rajeshri, madam, to proceed with her case.
Yes, ma'am. Thank you, Aparna madam, and good evening, all respected dignitaries and my colleagues and students. My today's topic is chronic kidney disease patient with hemoglobin of 7 grams per cent for the surgery of TORP. 70-year-old male patient with history of CKD since 5 years is posted for TORP. At present, the patient is having dysuria, urgency, and hesitancy during the urination. My pre-op assessment is that since from history, the patient is having the CKD since 5 years, and I have discussed with patient that he may need post-op dialysis procedure, and I have also inquired the daily urine output. In general examination, the general disease where he is febrile, pulse rate is 70 per minute, and blood pressure at present is 140 by 90 mm of mercury. On examination, systemic examination, CNS and CVS are within normal limit. RS is also normal, and per abdominal, no abnormality detected. From investigations, I have taken investigations like full blood count, clotting studies, LFT, KFT, and ECG, and chest X-ray, which are within normal limit. I have also taken shows no any abnormality. Urine analysis have also done and so asked that are normal. From optimization, I have not asked for any blood transfusion since this patient of CKD may need post of 2 hour desensitization. I have not taken blood transfusion. Injection erythropoietin may have role. So as TURP is a elective procedure, injection erythropoietin in IV 10 days before surgery can be given to raise the hemoglobin. My plan of anesthesia in this patient is spinal anesthesia and level required retain. So I have given drug injection bupivacaine 2.5 ml. Yes, thank you. And so to expert, my question is that how much intra fluid should be given in this CKD patient, as this patient is CKD and as TURP irrigation fluid may have. Hello.
Yes, madam.
Go ahead.
So my question is that how much intra IV fluid should be given to the patient? Hello.
Basically, yeah, you can clarify.
Question to the experts.
You can clarify a bit more when you say 5 years of CKD. Based on what you have told, I assume it is a medical disease. The CKD is due to possibly medical disease, because when you say prostate, it's obstructive uropathy leading on to, it's a risk for renal failure also, CRF.
Okay.
So you can please explain whether that 5-year-old history of CKD which you mentioned, is it because patient is a medical case, the chronic diabetes mellitus with renal involvement and low urine output, and there is any evidence of dialysis for the patient. So that 5 years long of medical CKD, surgical CKD because of prostate would have been attended earlier than 5 years, right?
Okay.
So
yes,
what you mentioned is a medical cause. Okay.
Okay. Patient is having hypertension.
Yeah.
Patient is having hypertension.
So normal, the commonest cause is hypertension and diabetes mellitus associated with that, which is a cause for medical chronic renal disease.
Yes, sir.
So we'll assume that this patient has got the same thing, and it is possibly precipitated by the obstructive uropathy produced by the enlarged prostate.
Yes.
So that has so incidentally, the patient has developed a large prostate and he has gone to a urologist, and they have decided to take up the case, right? So that's the situation. So one thing you said, your immediate question was how much of fluid you have to administer.
Yes,
right?
TURP.
So
In
because
this patient.
I would be happy to know what antihypertensives he is taking and how long he has been taking. It could be more than 5 years. Number one.
Yes, sir.
And these all chronic hypertensives are we call them as refer to them as those having chronic contracted blood volume per se. Okay, the blood volume per se would be reduced.
Okay.
And secondly, the CKD itself, medical, we don't call it as this patient is chronic renal dysfunction, right? So per
Yes,
se,
sir.
if they are not been properly managed, they would all have precipitated hypertension. There is risk of fluid overload. There is risk of pulmonary edema, right? So many other complications would ensue in these patients, okay, including protein loss in the patient because of the renal involvement. So these things would happen. So if you are managed, I assume that these problems were not there in this patient, basically. And most important factor is the size of the gland that is to be excised, the prostate, right? So bigger the size of the gland, so greater will be the time spent on the resection, greater will be the number of sinuses opened, so that much of blood loss will increase. Okay, and that is one part, blood related. Second is the fluid related. So more sinuses are open, more of glycine, which is a common irrigation fluid, more of it will get absorbed into systemic circulation. And there is a relative increase in the blood volume. Okay, so that's a paradox. There is an increase in blood volume, and majority of the times there won't be need to use increase in the IV fluids, which we use in other spinal cases. So we can just have the most minimum flows going to the patient. see that the blood pressure is maintained. So blood pressure is very important to be maintained because we want the renal flow to be maintained because it's a medical disease.
Yes,
Right?
sir.
So
Yes.
this increased absorption because of glycine being used for a larger gland, and sometimes if surgeon is slow with monopolar cautery, which is used, and simultaneously if you use greater amounts of IV fluids, definitely there is a scope for fluid overload. Okay, you got all the problems. Yeah.
My next question is that to take for a CVP line should be routinely done or not?
Not needed.
CVP.
No, CVP line is not advisable. It's not needed at all. Okay, so because when you say a CRF patient and coming for the TRP procedure, so means is a stable CRF patient.
Yes, yes, yes.
So indication is the surgery. I mean the prostate itself. Otherwise, the patient would have been in the 6th year of CRF, 7th year of CRF, or whatever, and you would have undergone repeat dialysis and other things. And if it is really bad, the patient is for renal transplantation. So this patient is well controlled chronic renal disease. There is a surgical problem for immediate correction. So that is, even the urologist would have used a lot of drugs, the alpha blockers and everything, finasteride, everything they would have used and stabilize the patient. They would have put a catheter sometimes, reduce creatinine for the patient, then take up. But because there is here a chronic renal disease background, please see that you don't administer more fluid. Probably, for example, you will end up administering not more than about 300 to 400 ml for about 40 to 1 minutes to 1 hour of surgery. And this fluid is mainly to see that perfusion is kept going, number one. And if you give more, and the gland is more, duration is more, definitely intravascular fluid absorption becomes more, and there is risk of all the systemic complications.
Thank you, sir, for the practical tips, and we'll keep all this in mind. Thank you, Rajeshri madam, for this case. Now I invite our next case presenter, Dr. Vrushali.
Aparna madam, can we thank Diwatiya sir? Sir has to leave for another meeting. Yeah.
Oh, okay. But we really want you throughout this session because you really give us very much practical tips and all. But yes, okay, sir. We are really thankful for joining this for joining this webinar, and we will be grateful in future also if you guide us in the same way. And we are really very much happy that being our first webinar, you really joined it and you guided us all with your all practical tips and all the vast knowledge. And on behalf of ISA Paradi Ambezogai branch, I really thank you for joining this webinar. Thanks a lot, sir.
Thank you, madam. So I'm sorry I have to leave because there's another meeting.
It's okay, sir.
But I just want to congratulate you, the ISA, Dr. Lohia sir, Dr. Tarkase sir, ISA Ambezogai Parli branch for getting active again. And of course, this is your first activity. I'm sure you will take part in many more activities.
Of course.
Yes, sure.
And national level. And thank you, Dr. Shilpa, for helping in getting everything organized. So thank you very much. And
thank you, sir. Yeah.
Thank you, Dr.
Thank you, sir.
Thank you, sir.
GC members.
Thank you, sir. Thank you.
Thank you. Good. My apologies.
Thank you. No, it's okay. It's okay, sir.
Okay, sir. It's okay.
No problem. It's okay. Sir. Next, I invite our next speaker, Dr. Vrushali Rajgire. She is also an assistant professor in the same institute, and she'll be presenting a case of a patient with hemoglobin 7.5 grams posted for ureteric stone removal. Vrushali, Dr. Vrushali.
Yes, hello. Good evening, respected teachers, colleagues, and students. I will narrate my case in short. My patient, 32-year-old female, presented to casualty 1 month back with complaint of lumbar region pain radiating from loin to grion since 1.5 months intermittently, and which pain was getting relieved with analgesia, and she neglected the pain as well. But again, pain after analgesia, pain again persists, and there were no history of fever, burning, micturition, and hematuria. No history, no significant positive medical and surgical history. My patient is conscious, oriented in time, place, and person, and she is a febrile at present. Vitally, she is stable. There were no cyanosis, clubbing, icterus, but pallor was present. On airway examination, it's normal. On systemic examination, no abnormality were detected. On investigation, HB was 7.5, WBC count was 9,000. All other investigation like LFT, RFT, serum electrolytes were within normal limit. On clinical symptoms, X-ray KUB was done, which showed ureteric calculi at the distal ureter. On this, USG was done, which suggestive of ureteric calculi of approximately 1.8 to 1 centimeter at uterovesical junction. I got the call for the assessment of this patient to plan for URSL. So my plan was to optimize this patient, as patient is having HB of 7.5. So I requested to get a physician's opinion. So physician admitted the patient on the same day, and he started patient on as patient patient got relieved with pain. So patient was admitted under medicine, and she was already investigated. So physician advised IV iron dextran, and oral hematinics also started. Patient was all right again for 5 days. After 5 days, she again started with renal colic at lumbar region, and again the same patient was posted for URSL. Patient investigated for HB. That time HB was showed 8.2 gram%, and WBC count was normal. So I just keep ready for cross match, and I did this case under spinal anesthesia after all proper confirmation of NBM and all things. And after spinal patient was stable, procedure was uneventful, and post procedure again the patient was started on oral iron supplementation and proper analgesic. So my questions for the expert are like is that if patient is having HB of 7, how should I proceed with the same URSL? Hello? Hello?
Yeah, you said open. Sorry, you said open procedure, right?
No, sir, URSL, ureteroscope.
Okay. So first thing is, yeah. So you did allow some time. You were allowed some time with medical management by the physician also, and the HP came up to 8.2 gram%, right? And number two, when
yes, sir. Yes, sir.
Yeah, you said
yes, sir.
Located in the lower third of the ureter. Okay, and it's posted
Yes,
for
sir.
URSL, and you are given spinal anesthesia, right? So
Yes, sir.
the same dictum
Yes,
goes
sir.
through and through, because it is the endoscopic procedure number one. There is no
Yes, sir.
bleeding at all, absolutely zero bleeding.
Yes, sir.
Per urethral procedure. Okay, there is no scope unless there is an extremely inefficient specialist who causes some damage. Otherwise, 99.9% of the times it is a safe procedure, no bleeding per se. So clinical evaluation, there is no evidence of history-wise, there is no dyspnea or nothing, functional limitation, okay, exercise limitation as Dr. Diveti was suggesting, no limitations at all. Okay, so it is safe to go ahead with giving with 7.5 gram%. Number one. Number two, I will just want to convey that there is always scope for reducing the duration of the procedure if indeed patient has got some symptoms still. That is, there is no need to try to blast the stone or remove the stone. So one thing that the urologist would do, or we can advise him to do, would be to just put a stent. Right. So when a stent is put without removal of the tumor, the stone, okay, so the patient will never have any colicky pain, right? And you buy additional time for improvement of hemoglobin.
Anemia.
That's why I said if there are symptoms and if you are not happy with the patient, you can allow the ureteroscopy to go on, and you can request the surgeon, sir, you please only put a stent. So that is definite management also. There is no issue. So patient will be very comfortable. You buy additional time of 2 weeks, 3 weeks, or even for about a month. The HP can still be improved, and you watch for improvement in the general condition of the patient. Okay. Otherwise, number one step is very safe to go ahead with spinal anesthesia with this level, no issue. There are some symptoms which you are not happy with, or if you are not happy with the surgeon, no, these are all some tricky things. You can always request them to just stent the ureter, then wait for some more time.
Okay.
That's it.
Thank you, sir. Thank you for your guidance, sir.
Thank you, sir, for the practical tips. And thank you, Brushali, for this case. Any questions to the experts again?
No, ma'am.
Okay. I would request our next speaker, Dr. Purnima Panchal, madam, who will be presenting a case of a patient with hemoglobin 8 grams per cent posted for emergency LSCS. Dr. Purnima,
Yes.
is she there?
Yes, ma'am. Yes. Yes. Good evening, everyone. My case is patient having HB of 8 gram per cent posted for cesarean section. My patient is 26 years old female, primary, with 37 weeks of pregnancy, with meconium stained liquor, posted for emergency cesarean section. In history, patient is having history of amenorrhea since 9 months. There is history of dyspnea on exertion since 4 months. Patient is from low socioeconomic strata. In past history, there is no history of any chronic disease like tuberculosis. There is no history of antepartum hemorrhage. There is no history of any parasitic infections and no history of blood transfusion in the past. On examination, the patient was pallor. Heart rate was 100 beats per minute. BP was 110/70 mm of Hg in left upper limb in supine position. In systemic examination, there is no abnormality detected in CVS, RS, and CNS. In per abdo, linea nigra was present. Uterine height approximately 37 weeks. Fundal grip cephalic presentation. In airway, mouth opening adequate and MPC grade 2. I have investigated the patient. In CBC, there was HB showing 8 gram per cent, and WBC, that is, there was leukocytosis, that is 13,000. Platelets were normal, and other investigations like PTINR, LFTs, RFTs were normal. Blood grouping and cross matching was done. After confirming the NBM status of patient, IV line was secured, monitors attached, aspiration prophylaxis was given, supplemental O2 started with simple O2 mask, left lateral position was given. My plan of anesthesia, subarachnoid block. Block was given in left lateral position with 0.5% bupivacaine 2 cc. After adequate level of anesthesia, surgery started and wedge placed under right hip. Intraoperative monitoring, ECG, SpO2, NIBP, heart rate, blood loss, and urine output were monitored. Drugs given intraoperatively after delivery of anterior shoulder, 10 units of pitocin in pint per given. To prevent PPH as prophylaxis, carbitocin was given 100 miles over 1 minute. And as patient was anxious, sedation was given. Intraoperatively, there was one episode of hypotension, that is 80/60 mm of Hg, and it was treated with injection mefentermine 6 mg IV. No other significant changes intraoperatively. In patient was shifted post-operatively to recovery room, and monitoring was done like heart rate, NIBP, and SpO2, and patient was monitored for any blood loss. My question to expert, if the patient comes with HB% for elective cesarean section, should we transfuse the patient or take for the surgery immediately?
So definitely I will want input from other colleagues also here who are also very busy in private practice. But 8 grams of hemoglobin with a usual blood group. Usual blood group, if patient should not be, for example, O negative. Right. So somebody like with a mother with O negative blood group, unusual blood groups, patient with AB negative blood group. I will always take care to advise the obstetrician to see that blood is actually mobilized and brought on table. Because we cannot predict which patient is going to develop some uterine atony and increased bleeding in the intraoperative period. It's one of the things we cannot predict in obstetric practice. Any other surgeries, we can somewhat predict that it can be a bleeding. So if it is an elective procedure, I don't have a problem. If there is a trial of labor, which is already done, okay, already patient has been stimulated with lot of oxytocin, trial of labor has been given, and that it has been posted for cesarean section. So the oxytocin receptors would become less sensitive. Okay, so you administer oxytocin after extraction of the fetus, and then you still there is a risk of prolonged duration of hypotonia. So there is increased risk of blood loss. Okay, so this is one major consideration, and that's the reason. So definitely negative blood groups, especially O negative, AB negative, you please mobilize it and keep it on the table. That's one factor. Rest of the blood groups, we have, of course, any of the positives, they are readily available. Majority of the times, there is no issue. So my point of view is only about the rare blood groups. So that's one aspect. Otherwise, you can go ahead with management of the patient, mainly because one thing is we have dealt with even more dangerous patients, but we always resort to general anesthesia in such group. Yes, bleeding patients, we have dealt with 4 grams, 5 grams, 6 grams and all. So even up to 7 grams. But there is a confidence level which starts at 8 grams %, basically. So if you are sure with, happy with your obstetrician. So we have got obstetricians who finish it off in 25 minutes and 30 minutes max. And at the other end, you have got some of them, unfortunately, may do it for an hour and more than nearly 1.5 hours. Okay, so that's the one which is of concern to us, basically. So that is the reason I said just check about the blood groups, check about the obstetrician's normal timing in terms of the duration of the procedure, right? And you can very well go ahead with that 8 gram % if you are happy with both of these conditions. Okay. And
again, here we have some role of tranexamic acid, sir. Again, we
Yes,
are here.
Yeah. Correct. Definitely. But before I speak about tranexamic acid, Dr. Rajeshri said she gave both oxytocin and carbitocin. So I don't think it is normally advised. Okay, it is
No,
like
preoperative before starting the procedure.
Not on
Preoperative can
table.
we administer? Yeah.
On table.
Yeah, not on table.
How much? Okay, if it is before cesarean section, okay. Yeah, Dr. Rajeshri.
Yes.
No, cesarean after extraction, oxytocin and carbitocin both are administered.
No. After extraction, pitocin was administered.
Then carbitocin, you said?
Preoperatively.
Carboprost or what?
Carboprost. Okay.
Sir, what is your opinion regarding carbitocin? What is your experience? I mean,
Yeah. Correct.
Is it really beneficial?
So there are again WHO some trials which have come. It is definitely an analog which has got longer duration of action. Okay, there is no need to have an infusion, set the rate of infusion. For example, even oxytocin. So there are some recommendations from the gynec societies. So, for example, one of them would say you administer 2 units initially. It was the most popular one, which many of our colleagues also follow across the world now. So then follow up with another 5 or 10 units. That is being done. And whenever there is a need for increasing the rate, again you increase the rate because the obstetricians say the tone has not improved. It has not contracted. Then you have to increase the rate again. So that way, carbitocin, a single dose is okay, and there is no need to adjust the rate of infusion. And it carries on.
For BPS to.
Yes. No, that's what I'm.
Sir, carbitocin, irrespective of PPH, we have to administer carbitocin.
No.
The patient is having low HB in this.
Yeah. No, that's what I am coming to. So current indications are it's not universal. It's not advised for all patients. Number 1. Number 2, the current indication is more restricted. Same thing. So if the obstetrician thinks that there is a greater risk of bleeding and a greater duration of hypotonia of the uterus. And for example, you have got a patient with APH, antepartum hemorrhage. Okay. So if it is still stable, so it is an abruptio placenta, patient is otherwise stable, right? So it is easier for us to give spinal anesthesia for the patient and manage. In fact, placenta previa, which is very much towards the fundus, it is more dangerous than an APH per se. Okay. So there we think about giving general anesthesia, or we have what is known as double setup also, technically speaking. So APH per se, abruptio placenta, if it is there, number 1. Number 2, prolonged labor, right? And complicated labor per se overall. A twin pregnancy is there and other things are there, the obstetricians nowadays advise and request us to administer carbetocin. Okay? As a matter of routine, it's not advised. Now, should it be used in patients with low hemoglobin per se? So that's the question.
Yeah.
So if it is there, we can very well use it
Yes.
alone as a separate drug. Okay.
I think
The only thing is rate of administration. I don't know how many of our colleagues in the group are using. Dr. Pankaj is also raising his hand.
Yeah, where is it?
both
Basically,
Parna madam
rate
and
of administration.
we are routinely using it, sir. We are routinely using it.
No, so
Yes.
people
Sir,
should
sir, for the
monitor
fear
for
of the
tachycardia.
PPH, we are routinely using
Yes, yes. No, my concern
tachycardia is there.
suggestion is
Pankaj sir wants to
tachycardia, sir.
add.
Tachycardia is one
Yes.
significant
Okay,
risk.
okay, tachycardia.
Yeah, please. Some of our colleagues.
Actually,
Sir.
I was just leaving and I thought I'll just listen to the last case. Good, I waited.
Yeah.
Because carbetocin has become my favorite, sir, over the last 1 year or so.
Yeah.
Ever since it has been introduced. The only problem is it is most ideal for any planned sections.
Yes.
100 micrograms given slowly over 1 minute at the anterior shoulder. But if the patient has been in labor, many times the patient is already on a pitocin drip or something of that sort. So it has been found that when patient has already received pitocin, then pitocin is already occupying the receptors. So then carbetocin may not act. So in every planned section, you can 101% give carbetocin. The results are fantastic. I mean, I'm regularly using it now for the last 1 year, as I said. I don't know how many cases I must have done, but with fantastic results. Give it slowly, no problems, nothing. We have never faced PPH, and maybe
Any contraindication in
case,
PIH? Sir, any
no,
contraindication
no,
in
no,
PIH
no,
patients?
no contraindication. Absolutely no contraindication. The molecule is like pitocin, as sir said. It is a longer acting pitocin, you can say. It is an analog, but the results are very, very good. Only thing is planned section, first drug of choice. If patient is already taken a pitocin drip or something, then avoid.
Okay.
That is the only thing. The results are very, very good. Maybe hardly before there was in private practice, we usually are more careful about all these things.
Yes.
And blood loss especially. And see, even in private nursing homes, not necessary that every hospital has a good staff to take care of the pitocin post-op.
Yes.
So from that point of view, the drug is given in. We are giving the drug, and after that, nothing is required. The duration of action is almost 3 to 4 hours.
Yes.
And if at all required, only my gynecologist tell me once in a while he has had to give prostadine, carboprostadine. Otherwise,
Same
nothing.
experience.
And just to,
We also have
and
the
just
same
to add,
experience.
and just to add, I mean, I've been hearing for the last 3 years regarding pediatric. I feel no one answered that query. In pediatric age groups or even in neonatal age group, the best replacement for blood loss is blood.
Blood, yes.
Like in adults, we say 20% loss, then you go ahead with blood. In pediatric age group, if the hemoglobin is less, we always keep blood cross-matched. And even for neonates and pediatric cases, especially neonates, I mean, I found that just volatile anesthesia, already the hemoglobin is low, and some vasodilatation, the patient can really go into hypotension. And not every OT has a neonatal cough, or many times the coughs don't act. So in over the long years, what I have found is replacement of blood in neonates is very, very good. Just
Sir,
to
what
add,
is
I
the
mean,
HB at which you should accept? What hemoglobin levels you should accept pediatric
in
patients for
adults,
routine surgeries? Pediatric,
there is,
pediatric.
yeah, in pediatric, up to as in adults, we accept 8 in private. The same can be kept for pediatric. There is no criteria. I have not come across any
Sir, but
criteria.
pediatric HB is slightly higher, no? I mean,
Yeah, so I was just coming to that.
that's what I want. Yeah.
Yes, most pediatric cases, what I have been seeing in private practice, I do thousands and thousands of them every day. I mean, over the years, and usually around 9 to 10, I easily accept without any problem.
Okay.
But if you have 8 and if it's a minor surgery, then we keep the patient iron pre-op. Or if it's a major surgery, say laparotomy or something, then we keep blood cross-matched. And we try to give 10 ml per kg or 20 ml per kg, depending on what type of surgery it is. But the best replacement is blood.
Yes.
And of course, iron is a very big thing today. Avoid blood transfusion. That was already well discussed by Dr. Sheikh. So iron is
Yes.
a very big thing these days.
Yes.
Avoid blood transfusion.
Thank you, sir. Thank you for guidance. Varna madam wants to add something. Varna madam?
Yeah, just say that started using it for more patients instead of oxytocin, using carbetocin, and the experience is very, very good, as sir mentioned just now. And only once in a while we had to give pitocin and also carboprost, because it was atonic uterus. But we have given with carbetocin also. After giving carbetocin, if the uterus is not contracting, we've given pitocin. And also once we had developed some allergic reaction, once or twice. So that should be kept on mind.
Madam,
Give it slowly.
pitocin after carbetocin,
drug.
pitocin after carbetocin, will it have any role? The molecule is the same. Exactly.
The obstetrician said that now the uterus is not contracting, so obviously we cannot go against them. So I had to give. But
No, so give
then
prostaglandin.
in that
Give a
case also
prostaglandin,
we
madam.
had given carbo.
Yes.
No, give a prostaglandin.
prostaglandin.
Don't give pitocin.
Yeah.
Don't
So
give
giving
pitocin and
prostaglandin is
carbetocin.
better choice, madam, rather than to give pitocin.
Can we repeat the dose of carbetocin, sir? Can we repeat the dose of carbetocin?
No, sir.
I mean, any role of that? Like sometimes we don't get an effect. We can repeat. So is it advisable? I mean, I don't know. I'm just
I've
asking
never
you theoretically.
never had to do it.
Okay.
Because usually that time we are gone. I mean, if it happens after 2 hours, if the gynecologist would take a call. But I don't think my
So
gynecologist ever told me he has repeated.
intraoperatively, if it is not retracting with carbetocin also,
It has never happened till
prostaglandins
today. That's what I.
also.
No,
Okay.
as I told you, it has never happened till today. That's why I'm
Yes, yes.
extremely happy with it.
Okay.
Yeah,
Thank you,
that
sir.
good
Thank you for your
also
guidance.
straight on me. Then
There have been
it's
studies.
a call for surgeon. Then it's a call for surgeon, no? If it
Yes.
is not contracting at all.
Madam,
It
what
has
has
never happened. That's what.
there have been studies. There are at least one study which I have clearly seen. For example, they have compared carbetocin, oxytocin, carbetocin with oxytocin also, study-wise.
Okay.
So the results were that all of them were similar,
Okay.
non-inferior. Like carbetocin was not non-inferior to oxytocin, was non-inferior to oxytocin plus carbetocin. Okay. So, but
Everyone has individual experiences. Yes.
no, there's an evidence that has come.
Okay.
And definitely repeating, I mean, adding oxytocin after carbetocin just because we have to sometimes cooperate with the obstetrician. So that does happen.
But what Pankaj sir, what Pankaj sir told to repeat, to give prostaglandins is a better option. No?
Yes, yes. No, that's a recommendation from the British group.
Yeah.
They definitely talk about 3 steps here. So first, definitely you can use oxytocin. Even in Britain, carbetocin is not used in all the patients. If you've got good obstetric setups, why should we think always about carbetocin?
Yeah.
It's no need. So oxytocin, right? The secondary drug are basically the carboprost. And then if you go, apart from carbetocin, there is still a mention of methyl ergometry.
Yeah.
So of course, we have stopped practice in our colleges for long.
Yes, Mithazine. Only
But British guidelines still say there is a scope for
Mithazine.
That's it.
In case of PPH, yes, sir,
you.
definitely. In case of PPH.
Right.
Thank you, Pankaj sir. And okay. Anyone wants to add something? Yes, Parana madam.
Can I make a comment? Just last month only I had a patient of atonic PPH, and I had already given carbetocin, and 40 units of oxytocin had gone. Then we also gave methergin, carboprost, everything, and the uterus was not contracting. Then finally we gave misoprostol, and with that the bleeding stopped. So that should be kept in mind. Also, in guidelines of management of PPH, they do mention repeat dose of carboprost, which can be, I think, given after half an hour or something. So the duration
Carboprost.
interval at which carboprost you are repeating, that is important. And that's it. But misoprostol, it worked very well. So when you tried everything, maybe just use misoprostol, and that works very well.
Thanks, ma'am, for this practical tip.
So are
And
we
I would
concluding?
thank you.
Are we
We have
concluding?
yes, we We are done with the cases. We have a last case. Should we continue or should we conclude, ma'am?
Actually, Dr. Bala Bhaskar, sir, last 5 minutes. Can you bear with us?
It's the last one?
Yes, sir.
Yes,
Yeah,
Yes,
it's the last one, last case. And we have our last speaker, Dr. Prasad Sule. He'll be presenting a case of patient with HB 9 grams percent, diabetic, patient of IHB, posted for fracture femur surgery. Dr.
Hello,
Prasad.
good evening all.
Just give a quick briefing of the case and your management.
Okay, ma'am. My case is 60-year-old female, which is came with chief complaints of pain in hip area, unable to walk and shortening of leg after she fall in the bathroom 15 days back. And she had no any history of that time head injury, loss of consciousness or vomiting. In past history, she is known case of diabetes since 15 years and on metformin 500 mg/d. And she has had a history of acute chest pain 5 years back, for which she was admitted in hospital and did angiography and angioplasty at that time. And since then, she was on tablet aspirin, clopidogrel, atorvastatin, and telma beta-XL. At present, patient has no any history of chest pain, palpitation, or breathlessness. Surgeon has already stopped aspirin and tablet clopidogrel since 7 days. On examination, patient vitals are stable. CVS S1 is to normal. Only thing is patient is mildly pale, and on blood investigations, all blood investigations are normal except the HB is 9 gram. On ECG shows T wave inversion in V1 V2 with ST flattening and left axis deviation with left bundle branch block with strain pattern. On echo there is a type 1 diastolic dysfunction with septal wall and anterior wall motion abnormality with mild AR and mild MR with ejection fraction of 45%. This patient is posted for PFN for femur neck IT femur. As this is elective surgery, so we did a correction, anemia correction with one blood transfusion before 1 day before the surgery, and one whole blood was reserved. Our plan of anesthesia was combined spinal epidural. We put a epidural catheter at L3 L4 with upward direction, and then we given spinal anesthesia with bupivacaine 0.5 2.5 ml with additive of buprogesic 90 mics, and intraoperative pulse and BP was maintained with intraoperative fluid was 2 ns point and 1 RL was given, and blood loss was 200 ml. And after the completion of surgery, we give sensory epidural top-up with 2 ml of bupivacaine diluted up to 10 ml with additive of 50 mg tramadol. So my question for the experts is, what is the acceptable level of HB in IHD patient? Is it same for as that of the normal patient, or it should be raised?
Can I answer?
Yes,
yes, sir, for you only. Yeah.
Yeah. See, what I feel is when you say cardiac patient, so one basic rule of thumb is we are expected to check the functional limitation of the patient before the so-called trauma. So as long as the functional limitation is not much, and for example, meds wise, you think patient is otherwise there is no issue at all. So the recommendations say that you have to link the hemoglobin values to the cardiac disease with manifestation. For example, with a patient with an active coronary disease, right? You say the patient was on aspirin, clopidogrel, and statins, and patient was on telmisartan, and echoes shows 45% or 40%.
Ejection.
40% ejection fraction. What I would want to know is, were there any regional wall motion abnormalities along with this EF finding?
Yes, sir. There is regional septal and anterior wall motion abnormality.
Anterior wall. So that probably I didn't hear. So that there is an ischemia which is there persisting in the patient with a EF of only 45%. And how much was his hemoglobin before you raised it up?
9.
9 before before preparing the patient.
Yes.
Okay. So that way, this is acceptable. Your whole approach is acceptable because the guidelines, orthopedic patients with cardiac disease they say you can even do it 8 gram%, because they also consider elderly age for the patient. It is geriatric patient with orthopedic problem with a cardiac disease, combination of three. So it is acceptable to go ahead with the patient with regional anesthesia. Okay, and had it not been the cardiac disease, right, for the patient, even that 9 gram% is acceptable for the patient without that also. So your approach, I think, is very good. And again, going back to tranexamic acid, right? There could have been preoperative daily oral tranexamic acid while you were preparing the patient with blood transfusion and all. And intraoperatively, tranexamic acid also could be used for these patients, because definitely this is one area where they have clearly found that there is a good reduction in bleeding in the patients. That's never an issue. So I think overall it's a good management in terms of practicality and in terms of existing evidences. No issues.
Sir, one more question is there. Whole blood is safe or packed cell is safe for
No, I wanted to comment on it. No whole blood. Definitely not.
Okay.
Whole blood, that's why I said during about 15-20 minutes ago, I just raised that topic. Whole blood has come back only in the scenario of polytrauma, in an acute situation. Okay. So if you indeed want to use you said you kept a backup of, I heard that you kept a backup of a whole blood.
Yes.
That whole blood, I think it is not advisable practically, and as based on evidences, you just again go ahead with the packet cells for the patient. If necessary, you then add the plasma and platelets for the patient. So packet cells will be the choice. Whole blood is recommended nowadays, but only for the special category of patients. Polytrauma with severe anemia with ongoing loss.
Sir, I want to ask one more question. Whether the GA is medico-legally safe, as this patient has also diabetes mellitus with she may have autonomic dysfunction also. So
no issue with GA. No issue with the GA for this patient. Okay, so for example, that's what when
which is better, combined spinal epidural is better or general anesthesia?
Yeah. So per se, for example, that's what I'm trying to tell, goes with your practice also. Left to me, for example, if you say, I can justify epidural also, epidural alone for this patient. Okay. For example, if the patient is not obese or heavily muscular, so patient has to be positioned for surgery. But epidural doesn't give that much of relaxation, right? But if the patient is already, somewhat asthenic, thin, nearly 85 years old, thinly built, epidural will work very nicely. Even just about 6 ml of lumbar epidural volume would work very nicely, right? But the same thing, we cannot afford to do it in a muscular person and a obese patient, because you have to position the patient. So the other limb will not be paralyzed. Apart from the surgical limb, there is no adequate muscle relaxation. So surgeon and the patient himself will have some discomfort. So that's one issue. And spinal anesthesia, for example, in an asthenic patient, very small structure, even spinal anesthesia with about 1.2, about 5 to 6 milligram of bupivacaine also would be more than enough in some of these patients here. Okay, so if you have, that's why I said it depends upon how much you have exposed to this field. So that will also do very good wonders in this set of patients. GA is always, we can always justify the use of GA, right? There is no issue, because, and you said diabetic patient is there. Diabetes means we will want to avoid general anesthesia per se. But
what
if
if
45% only the ejection fraction is very low, there is wall motion abnormalities, I want to be perfectly safe medico-legally, you can still go ahead with the general anesthesia with controlled ventilation, add up epidural analgesia for the patient. Or you can have one of the new blocks which is given for the fracture femur, right? You can have the combined sciatic and femoral and the obturator nerve block. On those things also can be done.
Sir, in this scenario, what if the patient is having the deranged PT-INR? So would you prefer PCV or then whole blood if the patient is having deranged PT-INR?
Whole blood. Yeah. So then still it is packed cells only.
Okay.
Right. So because we have to talk about only fresh blood, fresh whole blood, but the risk is fresh whole blood will add as a load. It's an overload on the patient's circulation. Okay. So there is a low EF already. It's an elderly patient.
So by administering Lasix, can we decrease the load if at all?
Yeah, everything we can do, provided you are ready to take up that responsibility. It's preparing a cocktail now.
Yeah.
So, yeah. So one leads to other. So theoretically speaking, if you write in theory, we do everything. Okay, but furosemide, so Lasix. So how much you want to give? You keep on give 40 milligram and 40 milligram increments to the patient. So what would happen? Does it precipitate hypotension? And telmisartan is the ARBs. Angiotensin receptor blockers are very dangerous because they can heavily precipitate the hypotension risk for the patients. So telmisartan with furosemide with the spinal and epidural acting, there is a risk of severe hypotension which may not respond to our usual doses, and you may be precipitating again some failure. That's the problem.
Yeah. Thank you, sir.
Thank you, sir.
Thank you,
Thank you, sir, for this guidance. I would request Dr. Bajwa, sir, to add a few practical tips. Dr. Bajwa, sir, is he there?
Bajwa, sir, has already left, madam.
Left.
Okay.
So,
Okay.
madam, can we open the
So,
session for the participants for questions? Any questions for the
participants have
participants?
typed in the chat box.
Yeah.
I don't think so. You have. Do we have enough questions to be discussed?
No,
Or
madam.
we have covered almost all the type of questions
All the type of
in
questions
the
were.
session. Yes. And
Yeah.
it's being late also.
Yeah.
Actually, yeah. So we have promised only 5 minutes further to Bala Bhaskar, sir. And
Yes.
so I think so we should conclude this session. And we are very grateful that Bhaskar sir, Bala Bhaskar sir tolerated us till end.
Thank you. Thanks
Yeah.
a lot.
Yeah.
Thanks,
And so I would like to thank the experts for this today's session, Dr. Bala Bhaskar sir, Dr. Bajwa sir, and Dr. Devatia sir for guiding us and making this webinar a success. I would also thank the national GC members, Dr. Manisha Katikar ma'am, Indrani Hemant Kumar ma'am, and Pankaj Gupta. Sir, SAM's office bearers, Balaji Hasegaonkar sir, Rajesh Tagadpalle sir, Avinash Bhosle sir, Anita ma'am, Vikas Karni sir, Shilpa ma'am, of course, for a constant support and encouragement and for bearing us for last 15 days. I would like to thank the Ambezogai Parari office bearers and also the arrangement who has done the Jenica Technologies, Ganesh and Varsha. I'm also very grateful to them for arranging this webinar. And I think so almost
I think,
every
yeah,
Yes,
maybe
yes,
since it's recorded, may I take one sentence? For last 1 month, Aparna madam has been really taking all the toll and dividing the things.
No, ma'am, it was a combined
And
effort,
to her
actually.
help,
Yeah.
Lohia sir and Sachin sir, they have really distributed, and all the members who have done the cases. We actually had a rehearsal session, sir, yesterday. 3 hours we rehearsed the things, and before that also. So a lot of effort by Ambezogai Parari branch, and also Parana madam who had joined, and I think you missed Cham sir
Yes.
also had joined for most of the time.
Yes. We are very much thankful for to Parna madam for the practical tips. These small tips are very helpful in practical
And
life. Yeah.
and our most driving force, I think, Balaji sir and Tagadpalli sir, we haven't heard from him. Our honorary
Yes.
secretary Tagadpalli sir, are you there?
Yes, ma'am, I am there.
Yeah. Can you just
Yes. He was also a
say
constant
something
support
for Bezogai
and
Parari?
motivation. He was also motivating, throughout this journey. And we also got very positive inputs from Tagadpalli sir. So, like we are now thinking of doing more webinars. You are all are ready to bear with us.
Actually, I was not knowing that you all are so much active, active participant or active members. I'm very happy to have such an excellent webinar. Thank you to Team Ambezokai, Aparna ma'am, and Sachin
Yes,
sir.
sir.
Really very thankful, and you have done a very excellent job.
Thank you, sir.
Thank you.
Yeah. Thanks a lot. And with this, I declude this webinar. Thanks everyone for joining and guiding us. Thank you. Good night.
Thank you, sir.
Good night.
Good night.
Thank you. Yeah.
Thank you, Lohia sir.
Good night.
Tarkasa sir.
Thank you, Parna madam.
Thank you,
Thank you.
Shilpa
Thanks a
madam.
lot.
Very much thank
Yeah,
you.
thank you, thank
Aparna
you.
Shilpa
madam,
ma'am,
thank you.
special thanks to you. Special
Yes,
thanks to
yes.
Shilpa ma'am.
Yes.
I
Aparna
know
madam,
it's
you
so
also took a
nice
lot of effort from
knowing each
yesterday.
other.
You
Thank
were
you,
Thank you,
you
Aparna
were
thank you,
madam.
busy
sir.
with your
No,
work and
it's a combined effort, and we will always be in touch now.
Yeah, and so you are so enriched with so many cases. The
Yes,
cases
yes,
were
we have.
really, really good.
Yes, yes.
It's
Actually,
really
the problem
nice.
with us is we do all the things, but we never document it.
yeah, that's the
So
main problem.
we will always do it in future.
And
Yes.
And
what I liked is each of your case or each of your presentation was so much in detail,
Yeah, it was
like,
versatile,
oh,
madam. Yeah, it was versatile.
yes,
yeah,
yes. Like,
yeah.
yeah, okay, this points also I have to consider. It was really good.
And these were actually these are the actually practical problems we are encountering in our day-to-day practice.
Yes, yes, exactly.
A special thanks to Shilpa madam. She has taken a
I
lot of
know
effort, and
it is,
she is
Yes,
really
Shilpa madam.
she is a really a
like,
great driving force for all of us.
Yes, madam. Yes. So
Tagadpalli sir, no, this is, see, the idea is totally Tagadpalli sir and Balaji sir. So, and Tagadpalli said, ha, चला काय मदत करायची करा, सगळ्यांनी पुढे या.
Yes.
So, सगळ्यांनी पुढे या was the spirit.
Yes,
But we did not have any experience, and still you bared with us.
Yeah,
This
yeah,
is very great.
फायनल
हा.
काय असं
that is
काय
हा, नाही
we
खरंच
all sail
म्हणजे
in the same boat. 10 years back even I was like
No,
that.
but
अरे कुठे ऑन करायचं हे पण माहिती नव्हतं.
now the next webinar we will do for MMC credit points, madam. So more participants will be joining this.
Yes,
So we will
yes.
go for that.
And maybe that initially what we had problem, no, we'll tell him ki don't keep 100 limit. काय होतं, those who have registered within 100, they only can join.
Yeah.
Yes, yes.
So आम्ही बोरिवलीला we had removed the 100 limit.
Okay.
So that we can remove. So even ज्यांनी 120वा ज्यांनी register केलंय, even that fellow can join.
Yes, yes.
That problem,
Great,
technical problems were there, but they will be solved next time, I guess. Even we were new to all this. So
No, but you really carried, you and your team
obstacles
really
are going to
carried well.
come. We have to face them. That is the policy. Yes.
Yes.
Thank you,
Yeah,
everyone.
thank
Now
you.
let's conclude this.
Thank you.
And thank you,
Thank you, sir. Thank you, sir.
thank you,
Thank you,
Balaji
Rajesh
sir.
sir.
Thank you.
Yes,
Balaji
thank
sir.
you, Rajesh
And
sir.
Rajesh sir, yes.
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 I'm
Thanks a
ending the
lot.
meeting. Yeah.
Yeah,
Yeah, yeah. Okay.
Thank you.
Thanks.